All right, everybody, welcome. Welcome. Today is benign hematology. And benign hematology is all the blood disorders except for cancer. So I've labeled this and tried to organize it for you with the phrase, who clots, who bleeds, who needs a transfusion, and we have to talk about white cells because I didn't know where to put them in the differential, so we have to throw them in there anyway. So that's how we're going to organize today's talk. So what we want to talk about here is we want to talk about what are the common benign hematologic disorders and their clinical significance in both primary care and acute care, because even if you work in primary care, sometimes you'll be doing something that is clearing the patient for, say, surgery or an acute care intervention, or maybe you're seeing them post-operatively. So you should have an awareness as to what these hematological conditions are, regardless of your setting, because patients will change settings and so might you. And then we'll talk about the different pathophysiology of each of these conditions. I'll give you a high-level approach to treatment. I don't want you to get stuck in the weeds of the treatment as much as I want you to understand what the problem is, how do we work it up, and in general, how are we treating it and why this way, all related to the pathophysiology of the condition. So if you understand the patho of these benign hematologic conditions, the way they're organized, you should do okay. So let's get this started now. So this is the most common blood test you will see, probably the most common test you will order. This is the CBC. And the CBC, what this is actually measuring. So it reports, obviously, as you can see here, it measures cell count, right? And I'm moving my toolbar here because it's like blocking my face screen. So the CBC is measuring things like blood count and hemoglobin, a host of, jeez. There we go. Hemoglobin, which is the oxygen carrying portion of the red blood cell. Hemoglobin and hematocrit have a relationship to each other. So you should have about three hematocrits to every one hemoglobin on average. So when you look at your CBC, you want to notice that differential. Does that ratio hold true? That ratio holds true of three hematocrits to one hemoglobin. And what the hematocrit is telling you, it's basically what percentage of blood volume is occupied by cell stuffs, namely red blood cells and the like. So it gives you an idea of proteins to liquid ratio within the blood. And so obviously, if you can see what that relationship, and also it assumes that it's a normocytic, normochromic red blood cell of normal shape and size. But the reason this is interesting and useful is because when you look at this low hematocrit to hemoglobin ratio, say if it's less than 3, that could be an early indicator of like a microcytic anemia, like iron deficiency or thalassemia or something. Because what's happening is you're saying there's a lot more water because these cells are smaller. And so therefore, these red blood cells are carrying less hemoglobin per volume. Now, the more common way you can interpret this is when you see a high hematocrit to hemoglobin ratio greater than, say, 3.5. That is generally an indication of dehydration, because what you're saying is there's less fluid in the vessel in the body, and there's more proteins in relation to the fluid. And so that's an early indicator of what dehydration might look like on your CBC. And when you see that, and then you see a bump in, say, the BUN and creatinine, what you're doing, and maybe you see a high sodium, you're building this picture just on looking at the labs as to telling, oh, that looks like dehydrated to me, and so you can hydrate this person. The other way is if you overhydrate, say, post-operatively, and you see this ratio is violated because they're, say, hemodiluted, that's important to know post-operatively, because you don't want to mistake somebody for bleeding when really the hematocrit is down because it's hemodilutional. So that's something else to pay attention to. And so the other thing this is helpful for is it gives you an idea overall, are you anemic? Right? Do you have enough cells in your body? Or conversely, are you polycythemic? Do you have too many cell stuffs in your body? So this is a quick bedside way to estimate hemoglobin from hematocrit or vice versa, especially if you're in a resource-limited setting, right? If you just have this one test or you're in the middle of rural somewhere, and this is all the information you have, you can make some educated guesses as to what might be going on here. Now, You all recall likely from your anatomy and physiology and previous pathophysiology courses that hemoglobin as a structure is what carries, allows for iron binding and allows for oxygen to be carried to all the vital organs. You know that hemoglobin, there are four chains of hemoglobin. There's two alphas and two beta chains, and each chain has a heme group. Well, with one iron atom. That means you can bind four iron atoms to each hemoglobin. That ratio matters, especially when you notice, well, your hemoglobin's normal and you look cherry red. What's all this about? Well, it turns out carbon monoxide has a higher affinity for the hemoglobin than does oxygen. So in a carbon monoxide setting, they may look well perfused, but they're not getting oxygen. It's a carbon monoxide that's riding that hemoglobin. So anemia, plainly defined, is a low hemoglobin, meaning you have low oxygen carrying capacity, even if the lungs and the heart are normal. And they can have this normal looking hemoglobin and still be hypoperfused if, say, in the setting of carbon monoxide poisoning, where the O2 is displaced and cannot bind. And so there is a reduced effective capacity for that. Now, if you pay attention to the CBC longer, you will see various indices that are also reported. You have an MCV, an MCH, and an RDW. Well, what's all this about? This is describing to you the different sizes of the cells and hemoglobin content and variations within the red blood cell as well. So let's talk about what the unit is. So what you're measuring here is something called a femtoliter. It's 1 femtoliter, 10 to the minus 15 liters. So what that means is 1 liter has 1,000 milliliters. 1 milliliter is equal to 1 billion femtoliters. So one typical red blood cell has a volume of about 80 to 100 femtoliters. Now, nobody gets in the weeds that way, and you'll probably never mention that again, but we needed to know, what does that 80 to 100 mean? It's in relation to the volume overall. And so 80 to 100 quadrillionths of a liter per cell, and that's what it's referring to there. So when we look at that, that is the unit of measure for these various indices. MCV stands for mean corpuscular volume. That's the average size of a red cell. Normally it's 80 to 100, and we call that normocytic. So if you have a normal MCV, we call that normocytic. If you have a low MCV, less than 80, we call that microcytic, microcytosis, commonly occurring in things like iron deficiency anemia and thalassemias. If you have a high MCV greater than 100, we call that macrocytic. And that's something you would see in B12 and folic acid deficiencies, or liver disease, alcohol use disorder, hypothyroidism, and certain medications can cause you to become macrocytic. So the MCV is your first branching point when you're trying to classify an anemia. So you're going to say first, anemic. Your next question is going to be, what kind? The way you tell that is you're going to look at the MCV as your first indicator of which way we're going to go. Now, the next index I want you to note here is the MCH. That's the mean corpuscular hemoglobin. That's the average hemoglobin mass per red blood cell. And this correlates with cell color. We call that chromasia. So you will see a low MCH, we call that hypochromic. Think pale. That's iron deficiency. The person's pale, they're hypochromic. High MCH is often seen in macrocytosis, and we call that hyperchromic. And MCH tends to parallel the MCV. So if the MCV is down in general, the MCH will also be down, but it's less specific. Now, there's a third index here called the MCHC, the mean corpuscular hemoglobin concentration. This hemoglobin is the concentration within the red blood cell. So again, low MCHC, hypochromic, iron deficiency, thalassemia. High MCHC, spherocytes, and we'll talk about what those horrible things are. Autoimmune hemolysis. Cells are small, but they're packed together. That's what high MCHC would tell you. What you want to take a look at here is MCHC helps you distinguish spherocytosis, high MCHC, from other microcytic states. So finally, the RDW, it's the stepchild of the indices, but it's useful. And it's useful because this stands for red cell distribution width. This essentially implies, or we hope it means, that the cells are about the same size and shape, and they're going to stack normally within the vessel. High RDW means wider variability in cell shape and size. That's not normal. We need to figure out why. Normally, what happens with a high RDW, there's a cell type called anistocytosis, and I'll show you that on the smear. But high RDW is common in mixed populations of cells. So for example, suppose you get a transfusion. Well, you've got cells now from Joe Schmo down the street. All of a sudden, they don't match your cells exactly. That could be a reason for a high RDW. Or if you say have iron deficiency anemia, well, early small cells are trying to pump out to compensate for the sake that you don't have enough oxygen carrying capacity. So that may be elevated because there's a lot of cell variability going on to try and make more. So some are small and some are large. And a normal RDW is seen in a thalassemia trait. All cells are small, but they're uniform. So that tells you, let me get this straight. It looks like you're anemic, but the RDW is normal. Maybe I don't need to get too excited. This could just be a thalassemia condition, which can be a benign finding in the certain population. So RDW helps you distinguish iron deficiency, if it's high, from thalassemia, if it's normal. RDW is high in iron deficiency, normal in thalassemia. Got that? So that's a way to tell the difference. So you'll see on the hemogram, which is what we call the CBC, by the way, you might see the hemoglobin is down, MCV is down. That tells you hypochromic, microcytic, MCH. Then you see the RDW is up. That tends to solidify your diagnosis of likely an iron deficiency anemia, short of doing iron studies. So in microcytic anemia, when you've identified that, low hemoglobin, low MCV, check the RDW. If that's elevated, good indication it's iron deficiency anemia. If it's normal, good indication that it's a thalassemia trait. In the macrocytic anemias, you'll see a B12 folic acid deficiency versus other causes. That's what you're going to go down that path. Why might we be this way? And then finally, in normocytic anemia, MCV is normal, MCH is normal, but the hemoglobin is down, right? So that means you're anemic, but you're not microcytic or macrocytic. What's going on here? Well, a normocytic anemia, then you want to do reticulocyte count to determine, is it a production or destruction issue? And I'll show you this on the next slide, but the CBC indices is like a mini diagnostic algorithm. MCV gives you the category, MCH refines the type of color of the cell, the chromasia, and RDW will point you towards the cause. So when you see the hemoglobin value, what's the first question you need to ask yourself? Is this person anemic? That's the first question you need to ask yourself. And how do you classify anemia types based on the CBC? Based on the MCV. That will tell you microcytic, macrocytic, normocytic. And then what are the major causes of microcytic anemia? Iron deficiency, thalassemia, and anemia of chronic disease. And I'll show you what those look like down the road. So the question is now, what is this normocytic anemia? What can cause that, do you think? Well, acute blood loss, or it's gone on so long that the body can compensate. So that would be anemia of chronic disease, right? Not an acute condition typically. And also CKD. And the big drivers of macrocytic anemia are the vitamin B12 and folate deficiencies, alcohol, liver disease, and certain drugs can cause it. Now, there's a final thing on this CBC, which is the platelets. So if you see isolated platelet that's low, meaning an isolated thrombocytopenia, with everything else being normal, this should trigger you to what's going on here, and we'll talk about ITP as we go through this. So the major take-home message in looking at the CBC is it's about pattern recognition. MCV points to mechanism, and line-specific changes will help you guide your differentials. So now let's take a look here at reticulocyte count and haptoglobin hemolysis markers. So first of all, what is a reticulocyte? Well, a reticulocyte is an immature red blood cell recently released from the bone marrow. So it has some RNA remnants. A reticulocyte count measures bone marrow response to anemia. So in general, if I'm doing a regular anemia workup or monitoring on someone, I will normally do a CBC with a reticulocyte count, because that will answer two questions without me having to bring the patient back. One, if you're anemic, is it because of destruction or a lack of production? So that's worth noting. And if the reticulocyte count is compensating, then you know that they're able to pump out more reticulocyte counts. If the reticulocyte count is high, that means that the bone marrow is working. And the anemia is likely then due to blood loss or they're being destroyed. Why? Well, because the body's trying to compensate and reestablish homeostasis. So if they're being destroyed or you're losing it, your bone marrow's like, hey, get to work. We need more. Pump it out. So you'll see that reticulocyte count start to go up. If, however, the reticulocyte count is low, what does that mean? Well, that means the bone marrow isn't keeping up. So what's this about? This is a bigger problem. Anemia might be due to underproduction. Well, what would make you underproduce? Well, maybe you're malnourished. Maybe you're not taking enough iron, B12, folic acid. Maybe you have anemia of chronic disease and you're in a chronic state of inflammation. Or God forbid you have a marrow suppression, maybe due to chemo or radiation. All of those are factors to consider, but it's not normal for the bone marrow not to respond to demand. Now, what is this thing called haptoglobin? Well, haptoglobin is a plasma protein that binds free hemoglobin released during red blood cell destruction. Hemolysis is red blood cell destruction. And why does low haptoglobin suggest hemolysis? Well, because it's being consumed to mop up all the free hemoglobin just oozing around in the body. That's uncontained. So the classic hemolysis lab pattern, this is the thing that triggers your brain to say, hey, red blood cells are being destroyed for some reason. Don't know why just yet. High reticulocyte count because the bone marrow wants to compensate. High LDH, high indirect bilirubin because that's a reflection of dying cells, and a low haptoglobin. Low haptoglobin because it's all being used up in the cleanup process of the leaky hemoglobins. So now, what about underproduction anemia? Underproduction, that's when you're going to see things like a low reticulocyte count, a normal haptoglobin, which means if the haptoglobin is normal, that means nothing's being destroyed here. We're just not producing. We're just not producing. So what I want you to take away from this is that a reticulocyte count plus haptoglobin answers the key question: is anemia from not making cells, meaning low reticulocyte count, normal haptoglobin? Or is it because it's being destroyed, high reticulocyte count, low haptoglobin? Okay. Now, take a look here about this peripheral blood smear. Now, this is something that would typically be ordered by hematology. And then you may be the first to see the result, especially if you do hospital-based medicine. But suffice it to say, you should know what we're looking for on a smear and what these different cell kinds mean in relation to what might be going on. So why would we examine, first of all, a peripheral smear? That's when they take the blood cell and they smear it on a slide, when the CBC gives you all the numbers you need. Well, the smear shows you things like cell shapes and morphologies that reveal mechanisms of disease. Now, these are things that machines can't explain. This is what you need a professionally trained hematology, hemopath eye to look at. I'm sure AI will encroach on this field and take over. However, for now, we still have molecular and hematologic pathologists looking at these slides. So what is a schistocyte? Well, a schistocyte is a fragmented helmet-shaped red cell. Its clinical significance is that red blood cells are being physically sheared in the circulation. Now, what do you think of might cause shearing of a red blood cell? If you've worked in cardiology or CT surgery, our big shearers are the mechanical heart valves. They can shear the cells. But other major things like DIC, thrombocytopenia purpura, Hemolytic uremic syndrome. Those are other shearing conditions. And the way you know that a shearing condition is going on is you will see schistocytes on the slide. Now, schistocytes means it's a life-threatening hemolysis until proven otherwise. You do not go to sleep on schistocytes. You need to figure this out because we're losing blood. We might be in DIC and all bad things are happening. So you need to make sure that we're not ignoring a red flag. So schistocytes are always life-threatening until proven otherwise. Now, there's a condition called microangiopathic hemolytic anemia. It's abbreviated MAHA before MAHA was MAHA. For our purposes, MAHA in this class means microangiopathic hemolytic anemia. It is a characterization of these conditions. And there are kinds. But the one I want to talk to you about is the one where you have schistocytes, an elevated LDH, and a reduced haptoglobin. There's another kind in which you can have a thrombocytopenia due to platelet consumption, and it forms microthrombi in vessels. That's a problem because what's happening is we're triggering a stress response in that. And that can lead to acute, specifically kidney injury and that's where you get the uremic phase. So this is where we're getting this syndrome, this hemolytic uremic syndrome. This is how it happens. So hemolytic uremic syndrome is a microangiopathic hemolytic anemia, a MAHA, and it's characterized by the triad of schistocytes are seen on the smear, LDH, and reduced haptoglobin will be seen on the lavender top tube that you drew, okay? Thrombocytopenia is happening because of platelet consumption in the form of microthrombi. The body is forming these microclots. What does that mean? This is not the spleen is eating it. It's the body's forming microclots using up our platelet reserve. And so if you're making these mini clots, then you're going to block blood flow to your vital organ, in this case, it's the kidney, and that's what the uremia develops from. So why does this happen? Well, what's triggering this inflammatory response is this endothelial injury, which is common in renovascular disease. Now, why might that be? Next week, we're going to talk about cardiovascular, but why might there be renovascular disease and endothelial injury? Uncontrolled hypertension is one reason. Plaque rupture. So you can have this renal vasculature that's offended, if you will. We've offended the endothelium. And a platelet-rich microthrombi forms in the small vessel, right? Because if you destroy it, the body wants to heal it. It wants to restore homeostasis. These sheared red blood cells, which produce the schistocytes, will consume the platelets, and it triggers this cascade that we're calling a hemolytic uremic syndrome. Now, you're not gonna go deep into hemolytic uremic syndrome other than to know there are several causes. The most common cause that you will probably see in primary care, or if you see children ever, or in the acute care setting, is going to be due to Shiga toxin exposure. Shiga toxin produced by E. coli. So, for example, this is the patient that will come and complain to you that they're having bloody diarrhea. Normally, it's after a foodborne outbreak of undercooked beef. And if someone says to you, bloody diarrhea, possible food poisoning, your brain needs to go to the worst possible scenario of Shiga toxin E. coli producing, and they may wind up with hemolytic uremic syndrome. These cases were on the nightly news shows for a while when there was when they do a recall on ground beef, or kids get sick at a barbecue or something. I was fine, and all of a sudden the kid is like on death's door, probably from the Shiga toxin, and they're developing this uremic syndrome here. There are other causes that can cause this, other things that can cause this uremic syndrome, things like chemotherapy, certain drugs. Pregnancy can be a trigger for this hemolytic uremic syndrome, autoimmune disease. So if you hear me say things like drugs, chemotherapy, pregnancy, autoimmune disease, what that should trigger in your mind is our inflammation lecture from week 1. So all of those cytokines and chemokines are now coming back, and here they're wreaking havoc in this system. So you will notice every week we bring back those cytokines and chemokines, and they wreak havoc in a new system. And so what we're looking for are these unifying themes along the way. So that's why that was the first lecture that we had done, is because the theme continues to come back and repeat itself. So The common presentation for like a hemolytic uremic syndrome will be something like after a GI illness, and your patient will say to you, oh, I'm tired and I can't do anything and I'm so listless. And they'll say things like easy bruising, or they'll have little petechiae. Decreased urine output is something that would be observed. You do the labs and you find them to be anemic. You do a smear and you see schistocytes. They're thrombocytopenic on the CBC. The BUN and creatinine is rising and the coags are generally normal. This requires that workup to investigate. The way this is treated, just in general, is supportive care and hydration. If the kidneys are really taking a hit, they get referred for dialysis, and you want to avoid drugs that exacerbate the condition. Certain antibiotics can exacerbate it. And then if they're having an infectious diarrhea, this is why we don't want to give things like Imodium right away. We kind of want people to have their diarrhea if it's infectious, because if you slow the motility, you set the stage for more toxin to be released, and we're not clearing the bug out of the system. So for that reason, we try to avoid anti-motility drugs in this Shiga toxin because of this hemolytic uremic syndrome. So we'll get into distinguishing this from the other major issues. So we'll talk about now hemolytic uremic syndrome, thrombocytopenia purpura, and DIC. Now hang on to this mnemonic, and then I'll show you another slide, and then you will see where this plays in. So there's a mnemonic called FAT-RN, and FAT-RN should have you think about what makes you think that this thrombocytopenia is happening. So fever, anemia, thrombocytopenia, renal and neuro involvement. Okay, so you're going to hang on to that FAT-RN in your mind, and here you go. This is all three conditions next to each other. This is the microangiopathic syndromes. The three of them are this: hemolytic uremic syndrome, thrombocytopenia purpura, and DIC, disseminated intravascular coagulation. So these are the three microangiopathic syndromes. You have HUS, TTP, and DIC. And the triggers you can see are different for each one. But the way you can tell the two apart is the thrombocytopenia purpura is the one that's associated with fever, anemia, thrombocytopenia, renal dysfunction, neurological symptoms. The hemolytic uremic syndrome does not typically have the neurological symptoms. That's more just renal. So that is the thrombocytopenia with the renal failure. And the DIC, that's the one with the whacked out coagulation factor. So these other two, the HUS and TTP, have normal coags, as you can see here. But only DIC has the abnormal coags, the prolonged PTT time, low fibrinogen, increased D-dimer. So take a look at this, capture a screenshot. I will upload it. You'll be able to refer to it. I made this after I made your slides. It's like, I think they need an easier way to visualize this. So that's how you got this. Okay, so that is who bleeds. Are there any questions about who bleeds? Okay. If you do, you can type them in the chat too, and I'll read them and work them in. So if you're bleeding, that's one thing. But now we need to talk about who clots. So first we did who bleeds. Now we're going to do who clots. Well, who clots, meaning hypercoagulable states. Before we get into who clots, we probably should review how we clot, because how we clot will tell us who's clotting and why. So a normal clot forms in 3 coordinated steps. The first thing that needs to happen is you need to have a vascular spasm. The blood vessel then constricts to limit blood flow to that vascular spasm. Then what happens is a platelet plug needs to form. The way that happens is platelets adhere, they get activated, and they aggregate, right? So you activate the platelets, they aggregate, and they adhere. Platelets activate, aggregate, and adhere at the site of injury. And this triggers the clotting cascade, in which clotting factors generate thrombin, which converts into fibrinogen, into fibrin. And this is what stabilizes that platelet plug. Get familiar with these terms, because it's all of these terms that get derailed that are the reasons people are clotting. Now, what's the role of calcium in this process? Well, calcium is factor 4. And factor 4 is required at multiple steps of this clotting cascade. It acts as a cofactor that allows the enzymes and clotting factors to bind to platelet surfaces. Hang on to that, because sometimes amidst a bleeding emergency, we do need to give them calcium. Now, without calcium, this cascade is stalled out, it's delayed, it doesn't take place. Keep in mind, calcium is the thing. This is the reason we put EDTA or citrate in your lavender or your blue top tube. The whole purpose is the blood in the collection tube is mixed with this EDTA or citrate to bind up that calcium in the blood to prevent it from clotting, so the lab can say, here's the number, rather than say your specimen's clotted, I can't do anything with this. So calcium is implicated in the clotting cascade. So how does this normal process relate to the various disease states with respect to hypercoagulable states? Well, pathologies occur when one part of this balance is tipped. So too much clotting, we get hypercoagulability. These are things like inherited thrombophilias, factor V Leiden, prothrombin mutation, acquired states, someone on oral contraceptives has a malignancy, someone that's immobile. Well, if we have too little, then we have bleeding. And that's when we talked about platelet disorders and factor deficiencies and hemophilias and Wildebrands and uncontrolled clotting and bleeding, that's DIC. So there's a framework I want you to hang on to, and you will hear this in clinical practice to help you think about the pathological clot formation. Many of you might be familiar with Virchow's triad. Virchow's triad are 3 things: stasis of blood flow, endothelial injury, and hypercoagulability, either inherited or acquired. If you have 2 of the 3, that generally sets the stage for a clot to form. A normal clot is a result of this delicate balance of platelets, clotting factors, and calcium. Now, every disorder we're going to cover, whether it's clotting, bleeding, transfusion, or white cells, represents a breakdown in one piece of this balancing act. So what does it mean when we say somebody is hypercoagulable? It means that their blood has an increased tendency to clot due to an imbalance between procoagulant forces and natural anticoagulants in the blood, right? So when we think about those 3 elements of Virchow's triad, stasis, such as what? Sluggish blood flow, immobility, atrial fibrillation. What about endothelial injury? Well, when we cut you, like in surgery, we want you to stop bleeding. So that triggers the endothelial injury cascade for the platelets to start going there. So endothelial injury in the form of surgery, trauma, catheters, all of that is traumatic to endothelial linings. And then inherited or hypercoagulable states can be inherited or acquired. So the thing you need to keep in mind is that most people with a venothrombotic event, DVT-PE, have 2 or more elements of Virchow's triad at play. So whenever you see a DVT, it's not just a DVT now. You need to think about, why are you getting this? And we need to trigger an investigation, and we'll talk about that investigation as we go through this. So let's talk now about inherited thrombophilias. How do you inherit thrombophilias fits into the normal clotting process we just reviewed? Well, think about what the line is. Thrombophilia. These are disrupted regulatory breaks on the coagulation cascade. So instead of turning clotting off once the fibrin is formed, these mutations let the thrombin continue to keep pumping out. That's the disorder. Despite the clot being formed, they continue to make clots. Let's see what this question is here. Virchow's triad is the clotting triad. So the most common inherited thrombophilia is factor V Leiden. Factor V Leiden, normally you have protein C, which acts as a shutoff to factor V. And it's slow thrombin generation. So with this mutation, factor V is resistant to inactivation. So the clotting keeps accelerating. The second most common cause of inherited thrombophilia is a condition called prothrombin G2O210A. Now, you don't need to memorize G2O210A, but you will see it if you find yourself in hematology. But what you just need to know is it's one of the thrombophilias. You know, there's more than one. And this doesn't change clotting factor function. It just increases the amount of prothrombin available. Now, remember, we're talking about who clots. So the more thrombin and fibrin are produced, the more likely you are to clot. So which deficiencies remove the natural break entirely? It's a protein C deficiency, a protein S deficiency, or an antithrombin deficiency. Protein C and S normally inactivate factor 5A and 8A. Antithrombin neutralizes thrombin and factor 10A. You don't need to know specifically all the factors to be memorized in your brain. You just have to have an idea about the various components of the clotting cascade, so when you order and do the workup, you will know what each of these components are contributing to your clinical picture. So without protein C, protein S, and antithrombin, without them, the cascade keeps running unchecked. These are the things that are pro-bleed, and they help balance the balance of clotting versus bleeding. So how might this present? Well, this is how you need to pay attention to this. If in a young person, someone has a strong family history, they present with a DVT, right? And clots are or if they develop clots in unusual sites, like say cerebral venous or sinuses or mesenteric veins, you're like, well, how will I know that? Well, what will happen is someone's going to come in complaining of dizziness, and you're going to do your usual $1 million, let's do some meclizine, let's hydrate you, let's check your CBC and anemia, but I'm still dizzy. Well, at some point, you're going to image their head. And when you image their head, you may see this unusual finding of a cerebral venous sinus embolism. You're like, hey, that's weird. We still have to treat that, but now we have to think about, why did you get a blood clot in this unusual vein that I just happened to stumble upon? So that's a way that you may stumble across these inherited thrombophilias. An inherited thrombophilia does not cause new clotting pathways. They simply remove the off switch in the normal clotting system. This results in persistent thrombin generation and a higher risk of venous clots. Pay attention there, venous clots, not arterial clots. Especially when combined with acquired triggers like what? Acquired triggers are surgery, estrogen, immobility, malignancy. So in your embolic workup, you're always looking for surgery, estrogen, immobility, malignancy. What are you looking for? Surgery, estrogen, immobility, malignancy. Anyone that sprouts a clot, you need to look for these things. You can't just treat the clot and say, God bless and be gone with you. What's interesting, though, is oftentimes you can't work up this clot completely until you get to the end of treatment. So that's another complicating factor in all of this. What's going on here? Oh, someone posted the Virchow triad. Very good. I see the chat popping up. All right, now let's talk about factor V Leiden. Now, what does this look like? Well, where does factor V normally act in the clotting cascade? Factor V is a cofactor in the common pathway. This helps prothrombin, factor 2, convert into thrombin, which is factor 2A. With calcium's help, factor 10A and factor V from the prothrombinase complex, this is the engine that drives thrombin generation. So how is factor V normally regulated then? Well, activated protein C turns factor V off by cleaving it and preventing excess thrombin from forming. Well, what happens if factor V Leiden then? Well, they discover a point mutation in the gene that makes factor V resistant to activated protein C. What's the net result is that factor V keeps working and thrombin production keeps accelerating and fibrin keeps forming. The normal off switch has failed. That's the pathology in factor V. So how common is this? Well, this affects about 5% of Caucasians. It's the most common inherited thrombophilia. And how does it present? By the way, I will keep asking this how does it present question because you may see this question somewhere. How does this present? Venous thrombosis, DVT or PE, where in younger patients, or blood clot in unusual sites like cerebral venous sinus, mesenteric vein. Risks multiply when this gets combined with acquired triggers. So how might this happen? Well, this is your young, say, female who happens to be on oral contraceptive. That's called an acquired trigger, right? Or they're smoking. So that's two acquired triggers. That's why we ring the alarm bell if any female is on oral contraception and smoking. Big deal. Those are two acquired triggers for a blood clot. And then, God forbid, we have to do surgery on this person. 3 acquired triggers, and they don't pump their ankles. 4 acquired triggers. Can you see how the stage is progressively being set for a thrombosis to form? So does factor V Leiden cause arterial clots like in strokes and MI? No, and that's the distinguishing factor. It's almost exclusively in veins. So factor V, does it create new clotting pathways? It does not. It just simply breaks the off switch. By resisting APC inactivation, factor V keeps fueling the prothrombinase complex. The more thrombin you have, the more fibrin you have, the more clots you'll form. All right. So how do we diagnose and manage this thing? Well, why don't PT or PTT detect factor V Leiden? Well, because factor V Leiden doesn't change the amount of clotting factors. It changes how factor V is regulated. The clotting cascade will still look normal in someone with a factor V Leiden. So how do you test for it? The test for factor V Leiden is the activated protein C resistance assay. It's the APC resistance assay. That's a blood test. Now, it's a functional test which shows clotting doesn't slow down when APC is added to the tube. The test you don't do, but you should know will be done and requires special consent, it's genetic testing. That's the DNA analysis test. This confirms the factor V mutation. The reason you need to be careful in doing this is we need to have a big old conversation with this patient as to what the implications of this genetic finding is going to be on their insurability down the road. We may not be wanting to open up that Pandora's box until we make sure so-and-so has their life insurance established and their long-term care insurance established. Because if this comes up positive, some insurances will not insure this patient. And so now we're stuck. So that's why we don't randomly do tests. We have to make sure it's a systematic approach, and the act of testing should not be harmful to them overall. So what makes this mutation clinically important in this DNA analysis? Well, in the cascade, factor V and factor Xa and calcium form the prothrombinase complex. That's what generates thrombin. When Leiden, that engine runs unchecked, unless something like an anticoagulant is introduced, it doesn't slow down. So how do you manage the clot in a patient with a factor V Leiden? Just like any other venothrombotic event. Anticoagulation, you can do DOACs, the direct-acting oral anticoagulants, the apixaban, rivaroxaban, low molecular weight heparin, warfarin, all of those are acceptable ways to manage a venothrombotic event. How long you do it depends on what caused it. So if it's a provoked clot meaning surgery, oral contraceptive, immobility, you're treating that about 6 months. If it's unprovoked, recurrent, or the person is homozygous, that's going to typically be extended or lifelong anticoagulation. That's definitely going to be a conversation you're having with hematology and genetics. And what about patients who test positive but never had a clot? Now, how might they test positive and never had a clot? Direct-to-consumer testing. Or someone randomly did this and didn't do the necessary follow-up. And then they come to you as their primary and say, hey, I tested positive for this factor V. Now what do I do? Well, the short and the long of it is, unless they have a problem, we're not going to prophylactically anticoagulate them. So no anticoagulation. Instead, we're going to do counseling and prevention. We're going to avoid estrogen-containing oral contraceptives. We're going to promote mobility on long flights and after surgery, and et cetera. And if they are in high-risk settings, we may consider prophylaxis then. So if I'm going to go on a 20-hour flight, or if I'm going to go into surgery, if you're doing that pre-surgical clearance, you want to raise that to the surgeon's attention and say, hey, don't forget DVT prophylaxis, and they all check the box pro forma. But they're like, no, no, in this case, it really matters that you put those SCDs on. It really matters that they get that low molecular weight heparin. So that's something to keep in mind. Factor V Leiden matters because it removes the APC brake on thrombin generation. But management isn't about just the mutation alone. It's about the clinical history and the risk factors and in what context you're expecting them to possibly clot in. No, APC testing is not genetic testing. Genetic testing is the other test. Okay. That question was in the chat box. Okay, here we go. Now, what about this other thrombophilia? Well, there's another one called prothrombin G20210A mutation. Now, where does prothrombin, which is factor 2, fit into the clotting cascade? Prothrombin is the precursor to thrombin, prothrombin. In the common pathway, the prothrombinase complex, made up of factor 10A, 5, and calcium, converts the prothrombin into thrombin, which then makes a fibrin clot. So what is the problem in this prothrombin G20210A mutation? Well, the problem is DNA has changed in the prothrombin gene that leads to increased prothrombin levels in circulation. There's a genetic change that has taken place. So why does this matter? Well, this matters because if prothrombin is the fuel, this mutation means that the clotting system has extra fuel on board. So we're really setting a fire. So when the prothrombinase complex turns on, more thrombin and fibrin are produced than normal. So what happens if you have more prothrombin and thrombin and fibrin? Clot. So how common is this mutation? This is the second most common inherited thrombophilia. 2% of Caucasians, very little in anyone else. So how do patients with this present, do you think? Same way the other ones presented. A venothrombotic event, a DVT, a PE. They're younger than expected age, sometimes in unusual sites like cerebral venous sinus, mesenteric veins, right? Risks increase when combined with triggers and acquired triggers like oral contraception, pregnancy, immobility, malignancy. Okay, and how is it diagnosed? This is purely through genetic testing. That's how this is diagnosed. Standard coagulation test will be normal here because we're not mucking with the coagulation cascade. The way this is managed, the same way the other venothrombotic events are managed. DOAC, standard anticoagulation, if we've caused you to clot with a scalpel, 6 months out. Lifelong if it's an unprovoked clot. And asymptomatic carriers, no anticoagulation, but they get the same counseling about risk factors of clotting and prophylaxis. Yes, pregnancy is a risk factor. And hormonal exposure, obviously, estrogen. What about this thrombophilic event or situation? Protein C, protein S, and antithrombin deficiencies. Remember, these are the braking systems, if you will, okay? So in the clotting cascade, protein C, S, and antithrombin are the natural anticoagulants in the body. They are the brakes on the clot formation. C inactivates factor 5A and 8A, and S is the cofactor that helps protein C work. Antithrombin neutralizes thrombin. It's in the name, antithrombin. And it also works on factors 9A, 10A, 11A, and 12A. So 9 through 12A. That's what antithrombin works on. You don't need to know all of those specifics. You should just have a general idea of these thrombophilias. Now, protein C deficiency. What happens if protein C is missing? Well, factor 5A and 8A stay active, and you form excessive thrombins. And then the clinical clue is what? Recurrent venous clots, family history, venothrombotic events. Same thing for protein S. Protein S, this prevents protein C from becoming fully activated. And this is another impairment to the clotting cascade. There are several types of this, but the way this presents also is the same pathway of the venothrombotic events. Same goes for antithrombin with respect to how patients will present and the management. So in short, we don't treat just the condition. They have to have symptomatology to warrant treatment. And if it's they develop a symptom with no provocation, that's typically the person that will get lifelong treatment. And the further down on this list we go, the more rare they become. Okay, so how do we approach the workup for somebody with a thrombophilia, an inherited thrombophilia? So should every patient with a clot be tested for an inherited thrombophilia? Hands up for yes. Let me see your hands for yes. I don't see any hands. Oh, one hand for yes. And I see a whole bunch of people just phoning it in with their cameras off. Okay, the answer here is no. We don't want to just test everybody who throws a clot for thrombophilias. Most clots are acquired. In other words, most clots have a very clear etiology: surgery, oral contraceptive, malignancy, immobility, etc. So testing everyone adds cost, causes confusion, and doesn't typically change the management. So then who do you consider testing? Here is who you're going to test for inherited thrombophilias: young people with unprovoked venothrombotic events. That's who you're going to test. And for our purposes here, the notes say young means less than 50. So people less than 50 with an unprovoked venothrombotic event, that should be tested. Patients with recurrent clots, they should be tested. Clots in unusual locations, cerebral venous, mesenteric, they should be tested. People with a strong family history of venous thrombosis, unprovoked venous thrombosis, not my mom had a DVT when she sat on the plane for 20 hours while she was pregnant and came to America. That's not the same. Which inherited thrombophilias are most clinically relevant to test for? It's the three I previously had on there. The three you test for are the factor V, the prothrombin G2O210A, and the protein CS and antithrombin deficiencies. So when we say thrombophilias, that's what we mean. And the way a positive test affects management is acute treatment is the same as any venothrombotic event, that is anticoagulation, but its long-term duration is influenced by whether the event was provoked or unprovoked, or if it's a recurrent situation. Asymptomatic carriers do not get anticoagulation, but they get good counseling and risk avoidance strategies. Those are the people that you would be cautious and not want to put on oral contraceptives that contain estrogen. Those are the ones that you want to really encourage the prophylaxis in high-risk situations. All right, so I want you to really get this clotting cascade. So think of this clot formation like it's a three-act story. Act one, the alarm goes off and you have initiation. A blood vessel gets injured, tissue factor is exposed, and this sets off the extrinsic pathway, factor 7 and tissue factor. This quickly activates factor 10, starting the common pathway. The amplifier kicks in, which is the intrinsic pathway. This is platelets adhere and release at signals that activate this intrinsic pathway. The intrinsic pathway are factors 12, 11, 9, 8. This pathway acts like a feedback loop, making more and more factor 10A. And then finally, the common pathway is activated. That's factor 10A5 and calcium to assemble this prothrombinase complex. This is the engine that converts factor 2 prothrombin into thrombin, 2A. Thrombin then converts fibrinogen into fibrin. Fibrin strands weave through the platelet plug. That stabilizes it into a durable clot. The problem occurs when the natural brakes are deranged. Protein C, protein S, antithrombin, those get deranged. They are not able to shut down the excessive clotting that's being done. Factor 5, the off switch has failed. In prothrombin G2O210A, too much prothrombin is being produced. In protein C, S, and antithrombin deficiencies, the brakes have been removed. The result of all these conditions is a hypercoagulable state, setting the stage for a venous clot to form. Okay, so let me just say a little bit more about other hypercoagulable states that are acquired. So now we talked about the inherited ones. These are the acquired ones. So acquired hypercoagulable states, depending on your setting, this may be more pronounced. So acquired hypercoagulable states are things that make you more prone to clotting that we gave to you, essentially. So far, we've talked about inherited. That's actually more common in practice, the inherited ones or the acquired ones. The acquireds are much more common, by the way, than the inheriteds. The acquired states often will overlap with inherited risks, but these ones drive up the risk of clotting more so. So what do you mean by acquired? Well, a condition that develops during your life and increases thrombotic risk by altering endothelial function, blood flow, or the coagulation cascade in some way. So what are some examples? Well, here they are on the screen. You have heparin-induced thrombocytopenia, antiphospholipid syndrome, malignancy, pregnancy, estrogen exposure, hospitalization, long flights, atrial fibrillation, surgery. Those are the things that are necessary to acquire a hypercoagulable state. So why are these significant? Well, because these are the real world drivers of unexplained clots in adults, unlike inherited states. And some of these are reversible. So once technically the trigger is removed, you can solve your problem. So what do you need to consider about this in terms of a primary care setting? Well, you need to recognize clot risk before prescribing hormonal therapy. That's why this really matters. And you always want to screen for acquired causes when patients present with unexplained thrombosis. If you're sending someone to surgery or hospitalization, you need to really drive home the risks of stasis and endothelial injury, meaning are they going to meet criteria in Virchow's triad? Also, finally, patients with malignancy or antiphospholipid syndrome may require extended prophylaxis. And heparin-induced thrombocytopenia needs to always be considered in patients with prior or recent heparin exposure. Just as a rule of thumb, recent meaning 100 days. And the exposure can be as simple as someone happened to use a heparin to flush an IV line. They don't do that anymore. Much more popular late 90s, early 2000s. And some of the old nurses will say, well, in my day, we used heparin flushes and the lines never clotted. Yeah, but there's a big problem that we need to watch out for. And here's one. Heparin-induced thrombocytopenia. So what triggers this condition is heparin binds to platelet factor 4. Remember that platelet factor 4 is a protein released from platelets. This heparin protein factor 4 complex is seen as a foreign invader by the immune system. So this is an antibody produced with the presentation of heparin. And what happens is the immune system produces IgG antibodies against this heparin protein factor 4. So the way these antibodies cause clotting is the IgG antibody binds to this protein heparin 4 complex on the platelet, and then it activates it. And the activated platelet then releases more protein factor 4. So if it releases more, what do you think is going to happen? More antibodies. This fuels a cycle. This aggregate then starts to form clots. They get cleared, and the platelet count goes down. So this is an autoimmune condition, essentially, in response to heparin exposure. So the thing that you need to pay attention to here is this heparin-induced thrombocytopenia paradox, in which the platelets are going down. That's the tell. But instead of bleeding with the platelets going down, the patient is developing new clots, especially venous emboli or thrombi. Emboli means it's in motion. So what the net effect is on the clotting cascade is that there is a massive platelet activation, there's increased thrombin generation, And a prothrombotic state has developed despite low platelets in the setting of heparin exposure, sometime in the last 100 days. So heparin-induced thrombocytopenia, is it a bleeding disorder or a clotting disorder? It's a clotting disorder. It's an immune-driven prothrombotic state caused by antibodies against heparin protein factor 4 complex. The paradox is the low platelets and the high clotting risk. It's the exact opposite. So, like, why can't you just transfuse platelets in this? Well, because it can fuel more thrombosis. You have more platelets able to reduce more PF4. So the transfusion is only used in these cases for life-threatening emergencies. Heparin-induced thrombocytopenia is a classic example of an acquired thrombophilia. The platelet count drops, but the danger is new clots. So always think about this condition in post-operative or hospitalized patients who have been exposed to heparin. So how might you think about it? They come into your office, they have a clot, the platelets are down. An alarm should go off in your mind to say, hey, have you been exposed to heparin? Now, they may not know, but that's when reading the medical record is helpful. And read the MAR and look at the flush report and think about any heparin-coated catheters, all of those things. Okay. Now let's talk about diagnosis and management. So what is the hallmark lab clue? Well, greater than a 50% drop in platelet count about 5 to 10 days after getting heparin. Heparin-induced thrombocytopenia can happen sooner than that, but if the patient was sensitized to heparin in the last 100 days, that's how come it happens sooner than 5 to 10 days. Besides thrombocytopenia, what clinical features should make you suspicious? A new thrombosis while on heparin is highly suspicious. So if someone's on a heparin drip, say in the hospital, and they develop a blood clot while on the heparin drip, it's not that necessarily the heparin drip or the PTT was subtherapeutic. It could be that you have triggered this clotting cascade as a result of an antibody reaction. So how do we structure clinical suspicion? Well, you use these 4 T-score. Thrombocytopenia, greater than 50%. Timing, how much time from heparin to clot. Thrombosis, did they develop a clot? And then the other T is for other causes, lowercase o, capital T, other causes excluded, meaning other causes excluded for developing a clot. So if you score 4 or more, there's an immediate high probability that this is heparin-induced thrombocytopenia. What are the 4 T's again? Thrombocytopenia, greater than 50% drop. Timing, 5 to 10 days out or sooner if they've previously been exposed. And of course, the development of a clot, T for thrombosis. And you've ruled out other causes. The lab test you can do to confirm this is a PF4 ELISA test. This is a sensitive but not specific test, which means there's a high degree of false positives. There's a more specific but not widely available. This is available at most of the university hospitals in the area. This would also be a send-out test in some of your other hospitals. But that other test is a serotonin release assay. That's the gold standard. So they do the PF4 because it's readily available, but it's the serotonin release assay that's the gold standard, and it's highly specific for diagnosing heparin-induced thrombocytopenia. Also, you do not want to wait for lab confirmation if the suspicion is high. If your suspicion is high, you need to treat this first. And obviously, what's the first step in treatment, do you think? Turn off that heparin. Stop flushing the line with heparin. Stop all heparin immediately, including low molecular weight unfractionated heparin. That includes flushes, and pull any heparin lines. No, it does not only happen while they're on heparin. It can happen up to 10 days after the fact, or if they've previously been exposed. They don't have to be on heparin to develop it. They have to have been exposed to heparin to develop it. Various catheters can be coated in heparin. Vascular catheters, various vascular catheters can be coated in heparin, not urinary catheters. Okay, so what do we do in this case then? So how do we treat heparin-induced thrombocytopenia? First thing, obviously, stop the heparin. The next thing is you need to treat that clot. So how do you treat the clot? Well, thrombin inhibitors are an option. The problem is you have to make sure that we didn't cause any renal or liver trouble with this clotting situation. Fondaparinux is another one, but it's off-label. And you can also, according to the American Society for Hematology, you can use DOACs, direct-acting anticoagulants, the rivaroxaban and the Eliquis and Xarelto and et cetera, et cetera. So those are things to do. They can get heparin-induced thrombocytopenia if they have been exposed in the previous 100 days. It typically develops 5 to 10 days after exposure. It can be manifested sooner than the 5 to 10 days if they have been previously exposed. Why? Because it's an antibody situation, right? So in order to make an antibody, I need you to be exposed previously, and then on your next exposure is when I expect you to get it. Okay, now let's talk about antiphospholipid syndrome. What drives antiphospholipid syndrome? This is autoantibodies against phospholipid binding proteins. Like what? Well, what are phospholipid binding proteins? Well, I'm going to tell you. And if you click the rheumatology panel in most of your hospitals, you will see this come up as options of tests you can choose. I don't recommend you click it unless you know what you're doing. But some phospholipid binding proteins include lupus anticoagulant, anticardiolipin antibodies, anti-beta 2 glycoprotein. These are 3 phospholipid binding proteins. So if you have antibodies to them, say like in lupus, despite the name, it doesn't cause bleeding. This causes clotting. Right? So instead, these antibodies activate endothelium complement and platelets, creating a prothrombotic state. So these are mechanisms by which people can clot. Antiphospholipid syndrome is one of those mechanisms. The major clinical manifestations, again, in most clotting situations are going to be venothrombotic events. About 70% of cases are due to venothrombotic events. So what you're noticing here is your patient will come with a venothrombotic event, and what I presented you with is all the different things you need to consider working them up for. So a DVT, pulmonary embolus, most common presentation. Now, in antiphospholipid syndrome, this is a little more severe because they can also develop arterial thrombi. So these people can present with strokes, TIAs, and myocardial infarctions and limb ischemia. So who gets this worked up? This is your acute cold leg. The out of the blue person, this is your young guy that had a stroke at 39 or 45 with no other major risk factors. This is he's a runner and he had a heart attack. My God, why? You have to look for these underlying conditions. Antiphospholipid syndrome. Other major things is in the setting of antenatal and peripartal care, recurrent miscarriages should clue you in to look for this. So this is someone that's had recurrent miscarriages or preeclampsia or HELP syndrome or placental insufficiency. These various clotting disorders have caused complications in a major system. When someone has that, you need to go looking for these conditions. So can antiphospholipid syndrome occur alone, or does it always require you to have lupus? It does not. Both are possible. This is common in people, more common in people with lupus, but you can have this as an isolated autoimmune condition. Secondary antiphospholipid syndrome is what typically occurs when you have systemic lupus erythematosus or any other autoimmune condition because you're in this pro-inflammatory state. That's why inflammation can be problematic when it runs amok. So when should you suspect this? Well, same thing as applies. Now younger here, though, is pushed down to 40. So a young patient under 40 with an unprovoked thrombosis, especially if the thrombosis is arterial or recurrent or in an unusual site, like say renal or hepatic or mesenteric. How does this present? This could be your acute abdominal pain and everything comes up negative, but that lactic acid is high and you send them for CAT scan and you see evidence of a mesenteric infarct, but we didn't know how we got there. That's an odd place to develop a blood clot. This is what makes you think of things like antiphospholipid syndrome. Now, why can the labs be confusing here? Well, the lupus anticoagulant prolongs PTT in vitro. However, you would think that means it's a bleeding risk. But the problem is in vivo, the patient is actually clotting. So in the body, it's bleeding, it looks like, but in the Petri dish, it's clotting. So the paradox reminds you that the numbers don't always match. That's how you know this is not usually the situation. This also should remind you you're not treating the lab, you're treating the patient. The patient's here with a clot. Treat that. History and context are more important than any lab value you can draw. So what is antiphospholipid syndrome? It's an autoantibody driven prothrombotic syndrome with systemic implications, usually in younger patients. It causes clots in both veins and arteries and pregnancy complications. That's like the hallmark feature of this condition. Okay, now let's talk about antiphospholipid syndrome diagnosis and management. So how do we diagnose this? There is a scoring criteria called the SAPPORO criteria, SAPPORO, which requires both clinical and laboratory values to be met. So the first thing you need to document is a vascular thrombosis, be it arterial or venous or small vessel, or pregnancy morbidity. And what is pregnancy morbidity? 1 or more unexplained fetal death after 10 weeks. 3 or more early pregnancy losses less than 10 weeks. Or history of preeclampsia or placental insufficiency. That is a clinical criteria that needs to be documented in addition to laboratory criteria. So at least one of those lupus anticoagulant, anticardiolipin, or anti-beta-2 glycoproteins needs to be abnormal. So if one clinical finding and one of those is abnormal, and you have to do the test on 2 separate occasions more than 12 weeks apart to avoid false positives, because false positives can occur because of infection and transient illness, then the antiphospholipid syndrome diagnosis can be made. It's a clinical pathological diagnosis. In other words, you need the clinical finding plus a positive lab finding on 2 occasions at least 12 weeks apart. And you also need an event and a persistent elevation in the antibodies. How is it treated? The same way the rest of these venothrombotic events are treated, right? Direct oral anticoagulation. You can do things like warfarin, which is less popular now. And you can do things like, and what you're targeting, by the way, if you are doing warfarin in this case, Coumadin therapy, you're targeting a high INR of 3 to 4. And not only that, they're on warfarin plus low-dose aspirin. Well, what do you do if the person is pregnant? Well, if the person is pregnant, then they do low-dose aspirin plus prophylactic low molecular weight heparin throughout the entire pregnancy and postpartum, usually up to 6 to 8 weeks postpartum. The reason that is because this has been shown to greatly improve the odds of a live birth. Because imagine if the placenta clots off, that's immediately setting the stage for fetal demise. And supportive measures in this, you want to avoid additional risks. So no oral contraceptive, estrogen exposure, no smoking, limit the immobility. And you don't want to jump on the first positive finding because there's a high risk of false positives. So you always want to confirm it before applying this label. This label is very sticky. It doesn't go anywhere. So don't apply a very sticky label prematurely. Okay. Oh, you should also know you don't just diagnose antiphospholipid syndrome only if the antibody test comes back positive. That's not enough. You have to have an event and a persistence of the antibody test, not just one positive test, therefore you have this. That's an important criteria because it's lifelong anticoagulation. So that's why you want to be very careful in applying the label. Now, what are some other acquired risk factors for thrombosis? Well, these are pretty common, and if you've been in any practice for any length of time, you'll know this. These acquired causes are the much more common. These are the things you'll see in daily practice. But malignancy, So how does cancer increase your risk of clots? Well, tumors create and secrete procoagulants and cytokines, and these also may compress blood vessels directly depending on how large this tumor is. Which cancers are the highest risk for causing this? Pancreatic, ovarian, brain, and lymphomas are the highest risk, but any cancer can cause this. You can have an indolent prostate cancer that makes this high thing go up. Sometimes the clot is the first sign of malignancy. Sometimes the person feels fine, looks fine, they get a blood clot, you start investigating the cancer, and then you find it. So if a patient has an unexplained VTE, you always have to consider an occult cancer investigation. Now, what about immobility? Well, this goes without saying. Venous stasis, surgery, hospitalization, long flights, long car rides. All of these are double hits, essentially, in the Virchow triad. So these are the most common and also most preventable. Oral contraception. Estrogen increases clotting factors and decreases natural anticoagulants. So that's why it makes the risk even higher. So the older you are, and then you introduce smoking, which causes endothelial damage, given this underlying possible inherited thrombophilia and oral contraception, you can quickly see how the risk greatly increases. So this is why a really good history is super important. You can't just gloss over it. And you should review the ROS when they fill it out for you. Why would pregnancy be a hypercoagulable state? Well, pregnancy is an adaptive mechanism. The purpose of pregnancy is to procreate, save the mom, and save the baby. Well, in order to prevent that, in order to maintain that, the body knows it's going to be at high risk for bleeding given delivery, so the body does go into a hypercoagulable state. Pregnancy combines hypercoagulability and venous stasis and vascular injury, which is basically the trifecta for a blood clot to form. And the highest time of risk in pregnancy for a blood clot to form is the third trimester and the first 6 weeks postpartum. That's the highest time period when a blood clot can happen in a pregnant woman. Now, the acquired risk factors, again, please know them. Is there malignancy? Is there immobility? Is there hormonal or pregnancy exposure? When you hear those three, that's the thing that's helping that you need to consider when working up any sort of clotting situation. Genetic thrombophilias get tested on exams, but in real clinical practice, it's the acquired risk and the clinical presentation that matters. Let's see. Let's see some comments here. There's some discussion in the chat about maternal health in relation to this. Feel free to review it. Now, take a look at this table here. This is comparing various hypercoagulable states. So what are some examples of inherited thrombophilias? Let's review. Factor V, prothrombin G2O210A mutation, protein CS deficiency, antithrombin deficiency. How do inherited thrombophilias cause clotting? Through genetic changes that, number one, resist the natural anticoagulant regulation, such as factor V Leiden. Or number two, increase the procoagulant activity, such as in the prothrombin mutation. Or in the protein CS and antithrombin deficiency, there's a reduction in the natural anticoagulants of the body. What clinical features suggest an inherited disorder? Earlier age of onset, recurrent VTE, strong family history, clots in unusual sites. Those are strong clinical features that suggest this disorder. And how are inherited thrombophilias diagnosed and managed? Functional assays, confirmatory genetic tests, and then you manage the venothrombotic event with anticoagulation. The duration's guided by whether it was provoked or recurrent or unprovoked. What are some examples of acquired hypercoagulable states? Heparin-induced thrombocytopenia, antiphospholipid syndrome, malignancy, pregnancy, estrogen, and immobility. How do they cause clotting? Antibody-mediated platelet activation in heparin-induced thrombocytopenia and antiphospholipid syndrome. Or in this case of surgery and malignancy, it's due to the endothelial dysfunction. What about in terms of immobility? Altered blood flow leading to venous stasis and hormonal effects of estrogen and pregnancy. The clinical clues is the temporal relationship to the trigger. When did you get the heparin? When did you have the surgery? When did you start the oral contraception? Are you postpartum? In antiphospholipid syndrome, the unique feature there is sometimes the clot is arterial. The way it's diagnosed is through antibody testing, clinical context, and recognition and timing. So this table is just a snapshot of all of them to kind of give you an idea to refer to. All right, so why don't we take a 15-minute break now, and then we'll come back and do who bleeds. So we're done clotting. Now we're going to start bleeding. And then after that, we'll do who needs a transfusion. Actually, let's just make it 10 now, and we'll do another 5 later because I could see this getting pretty dense. 10-minute break. All right, so welcome back. Here we go. Let's talk about who bleeds. Now, we've spent the last hour and a half having clots. Now we're going to spend the next few minutes discussing bleeding. So if a clotting disorder are on one side of the hemostasis balance, on the other side, we have bleeding disorders. These are conditions where the body fails to form or stabilize clots effectively. Now, what are the main categories of bleeding disorders? Where you have 3 categories. So if you're bleeding excessively, there are 3 buckets as to why this may happen. The first is a primary hemostasis problem. So what does that mean? Well, what are the components responsible for hemostasis? That would be something like either a platelet disorder or something like von Willebrand's disease. A secondary hemostasis problem would be clotting factor deficiencies like, say, hemophilia A or B. And a consumptive state would be like a mixed condition of clotting and bleeding. And when they say consumptive, what's being consumed are the blood components and products like the clotting factors and the platelets. So disorders like DIC, where clotting factors and platelets are used up. And that leads to both clotting and bleeding disorders. So the 3 buckets for bleeding disorders in general are primary hemostasis, that's platelets and von Willebrand's, secondary, which are the hemophilias, and consumptive states. These are the 3 reasons, consumptive mean DIC. These would be the 3 reasons why someone is bleeding uncontrollably. Now, the net result of a bleeding disorder is the impaired ability to form stable clots, which leads to excessive or prolonged bleeding. So why does this matter clinically? Well, in the perioperative setting, obviously a bleeding disorder can affect pre-op risk assessment, anesthesia planning, perioperative management, all of those factors. But in emergency care settings, rapid recognition is the thing that's driving the resuscitation and the correct product replacement. And we'll talk about transfusions at the end. In primary care settings, subtle signs like easy bruising, menorrhagia, family history, those are the first clues that may point out to you that we have a bleeding disorder. So what diagnostic framework helps you in a patient that you want to address a bleeding disorder with? So the first thing you always need to ask is this a platelet problem, a clotting factor problem, or a consumptive process? Is it a platelet problem, clotting factor problem, or a consumptive process? And also, how does the bleeding pattern help you distinguish the underlying cause? So for example, if the person is having what we call mucocutaneous bleeding, nose bleeds, gum bleeds, petechiae, heavy menses, that would be a primary bleeding disorder. So that's where you would investigate for things like platelets and von Willebrand's disease. If, however, the person is having deep tissue joint bleeding, things like hemarthrosis, muscle hematomas, that's where you would then go to look for coagulation factor deficiencies like the hemophilias. The bleeding history is the single most sensitive screening tool, better than any lab test. So a careful history can help detect about 80% of significant bleeding disorders before labs are even drawn. Now, what are platelet disorders? Well, these are problems with primary hemostasis, either because there are too few platelets, meaning a number problem, or the platelets are not functioning properly, poor quality. So is it quantitative or qualitative platelet disorder? What happens when platelets don't work or there's not enough of them is that the body fails to form an adequate platelet plug at the site of vascular injury. So how do these usually present in clinical settings? Well, these are the ones that present with mucocutaneous bleeding. What's mucocutaneous bleeding? Nose bleeding, epistaxis, gum bleeding, petechiae, purpura, menorrhagia, prolonged bleeding after a minor trauma. This contrasts with clotting factor deficiencies in which those cause deep muscle or joint bleeding situations. The key examples of platelet disorders, one is von Willebrand's disease. This is the most common inherited bleeding disorder. It affects both platelet adhesion and factor VIII stabilization. Another platelet disorder is ITP, immune thrombocytopenia purpura. Now, this is the most common acquired thrombocytopenia. This is caused by autoimmune platelet destruction. The body is attacking the platelet. So why do platelet disorders matter? Because in the periop setting, you've got lower dysfunctional platelets, and this is greatly going to increase your risk of bleeding during surgery or an invasive procedure. Something as invasive as like a central line placement. In primary care, heavy menstrual bleeding or frequent nosebleeds are often the first signs of an underlying platelet problem. So you always want to ask, in the platelet disorder, is it an issue of quantity or quality? And if it's quality, we're talking about things like von Willebrand's, which is technically both platelet function as well as clotting factor deficiency. Or in ITP, where the bleeding risk doesn't match the platelet count perfectly. So most bleeding in mucocutaneous, we consider mucocutaneous until your platelets drop below 10,000. So until your platelets go below 10,000, we're going to treat this as if it's a mucocutaneous bleed. Platelet disorders are the most common bleeding problem that you'll see in most settings. And the pattern of what we call mucocutaneous bleeding, that's the diagnostic clue. Now, what is the most common inherited bleeding disorder? That's von Willebrand's disease. So the two main roles of von Willebrand factor is this mediates platelet adhesion to subendothelial collagen, which is essential for primary hemostasis, and serves also as a carrier protein for factor VIII, which protects from degradation, and this supports secondary hemostasis. So to form a clot, we need the platelet to stick, and we need to have the clotting factor. So what happens if von Willebrand's factor is deficient or dysfunctional? This is when patients would have difficulty forming a platelet plug, or if they have reduced factor VIII activity. This results in that combined defect in which platelets do not stick together and the clot is not stabilized. You need a clot that will stick and stay. So there are three different types of von Willebrand's. The most common is type 1. That's a partial quantitative deficiency. It's autosomal dominant, and it's mild to moderate bleeding. There are other types, but for our purposes, and by the way, this is going to be managed in hematology, so I would recommend that's where those patients will go. But for your intent purposes, know that there are three different types of von Willebrand's, and it's both a platelet and factor VIII problem. So the most common manifestation of von Willebrand, this is your person, I get frequent nosebleeds, I have gingival bleeding, even though I floss every day. This is not that I flossed once and my gums are bleeding. They get easy bruising, heavy menstrual period, prolonged bleeding after dental work. These are the things you should be listening for. Prolonged bleeding after surgery, trauma, GI bleeding, especially with angiodysplasia. So, you know, these are like varicosities or things. That's who might have trouble with this prolonged bleeding. Severe forms may mimic hemophilia due to the factor VIII deficiency, but suffice it to say, how is von Willebrand deficiency different than hemophilia? Well, von Willebrand's affects both men and women equally. Because it's autosomal inheritance. Hemophilia primarily affects men, and that's a way to tell it apart as well. Now, the bleeding history is often lifelong. That's another clue. Kids may be labeled as easy bruisers, or women may be enduring years of heavy periods before they're ever diagnosed. Clinical severity varies widely. Some patients have only mild mucosal bleeding, while others can develop major perioperative hemorrhages. And von Willebrand's is common, but really underdiagnosed. So recognizing those mucocutaneous bleeding patterns and family history is essential before any lab tests are ordered. So what's the first and most important step in evaluating a possible von Willebrand's? Well, detailed bleeding history is number one. The labs will confirm, but the story needs to raise suspicion. So I'm driving home the same point I say to you every week. We don't just do random labs and hope for the best. You need to have an index of suspicion before you order the labs. And the initial labs that will support this diagnosis, the CBC may show you an anemia if bleeding is chronic or heavy. The PT will usually be normal. A PTT may be prolonged because factor VIII can be low. So prolonged APTT, normal PT, mildly or anemic in the CBC. So which is the specialized test? Well, there are some specialized tests. There's von Willebrand factor antigen and von Willebrand factor activity. The antigen measures the amount of von Willebrand factor. The activity measures how well the factor is mediating platelet adhesion. You can also draw a factor VIII activity assay, which is often reduced in von Willebrand's factor. Now, it's important to know that these tests often need to be repeated. We don't take a one shot and done. In von Willebrand's factor, the levels fluctuate with stress, hormones, inflammation, pregnancy, even blood type. It's lower in type O people. But its abnormal results need to be confirmed on two separate occasions. So that's why clinical history and lab draw refer to hematology. They get the second lab draw and draw out the more history. You always want to correlate the labs with clinical bleeding history. A mildly abnormal lab without symptoms is usually not clinically significant. So if they don't have a matching bleeding history, but they have positive lab findings, that may not be significant. And false negatives are often common if the labs are drawn during stress, illness, or pregnancy when von Willebrand factor is normally elevated. And hematology referral is often needed for definitive subtype diagnosis. Well, what about immune thrombocytopenia? Well, what causes this? Well, this is also an autoantibody, IgG, target of platelet surfaces and glycoproteins. And these antibody-coated platelets are cleared prematurely by the spleen. The spleen is the repository of where cells and cell parts go to die. So does ITP only destroy platelets or does it affect their production? Well, actually both. Antibodies impair the megakaryocyte platelet production in the marrow. So that adds. So it's an underproduction problem and then it's a destroyed on arrival type of problem. So the result is this isolated thrombocytopenia, but everything else is normal in the blood work. Normal CBC, white count, etc. But the platelets are just low. And what are the two types? There are two types. You have primary and secondary. The primary is what we call idiopathic autoimmune condition. It's most common. Can't really say definitively what's causing it. The secondary, this typically occurs in settings of infection.
Neurotic.
Silence your microphones, please. So the initial management for ITP is that treatment depends on platelet count and bleeding severity. If platelets are less than 30,000,
this time, so she urinated fine. CPT, she was pathogenic.
Okay, let's go on to ITP now. So the big thing here with the approach to this bleeding workup is going to be important for you to have pattern recognition. So the patterns you're looking to recognize are the CBC with platelets, the PTINR, and the APTT. Other things in the workup include fibrinogen, D-dimer, and some quick definitions you need to anchor your knowledge in what these tests are actually checking for, because they're among the most common that you will do. PTINR, this is an extrinsic pathway, checks for factor 7 and common pathways. APTTT is the intrinsic pathway that checks for factor 8, 9, 11, and 12, and that is reflective of the common pathway. So two different pathways are being checked with the PT and the PTT. Fibrinogen is a substrate for clot formation, and the D-dimer reflects the fibrin breakdown product. It signals clot formation and lysis. You have to be careful because D-dimer can be falsely elevated in the geriatric population, but it's a little bit of a Pandora's box. Once you open it, then you're stuck having to chase it. So you may find a high D-dimer in someone that's already formed a clot, like a PE or a DVT. So the pattern recognition is what helps you decode these labs. The lab shows an isolated thrombocytopenia. What rises to the top of your differentials? Well, platelet disorders. Is it ITP, TTP, marrow suppression? Is it drug-induced? What are the reasons that this lab value is abnormal? If you have a prolonged PTT with a normal PT, well, what pathway is implicated based on what I've just told you? Well, that would be the intrinsic pathway. So now you're thinking hemophilia AB, von Willebrand's due to a reduced factor 8. Well, what if you have a prolonged PT with a normal PTT? What does that suggest? Well, that would be the extrinsic pathway, factor 7 deficiency, vitamin K deficiency, or early liver disease. So it's interesting. Part of your liver profile workup, I tell people this is your PT-PTT is very telling of liver function, because you realize in order for an LFT to be elevated, the cell needs to die and leak out. Well, before that happens, and the body's really great at holding itself together, you may see the first derangement occur in the coagulation profile. So what if both PT and PTT are prolonged? Now what category are you in? Well, now you're in the combined defect category. Now, if you did not give them heparin or Coumadin and the PT and the PTT are prolonged, now you're thinking DIC or significant liver failure or severe vitamin K deficiency, or they've had a massive transfusion. So obviously this is going to be something you'll generally see in the acute care setting. So normal, what about now if you have a normal PT and PTT, but the patient bleeds anyway? Now what do you suspect? Well, if it's a normal PT and PTT, now you're thinking platelet function disorder. And if your platelet count happens to be normal, well, now you can narrow yourself down to a quality of platelet diagnosis. So that helps narrow the differentials. So once you see a pattern, then what's next? Well, the next thing you're going to do is maybe you'll draw the von Willebrand disease assays, the factor and the agent, to look at the agent and activity, and maybe factor 8 and the like. But that gets to be downhill and in the domain of a hematology consult. But just to give you an idea, that's where this is going once you've done your baseline tests. And you have now, as a result of doing this, can formulate a consult question for hematology, which is a major thing in primary care. What question do you want to answer? Well, now you can say the PTT is normal and the PT is prolonged, or vice versa, or platelet count is normal and bleeding persists. Now you can formulate a consult question. This is especially true in acute care settings because the consult services are very busy and they're going to say, what is the question you want me to answer? So this is how you can help formulate your question. Okay, so let me just summarize here. Rapid fire, here we go. Mucocutaneous bleeding, platelet dysfunction, von Willebrand problem. Deep tissue or joint bleeds, that's coagulation factor deficiencies. Maybe we're going down a hemophilia pathway. If they have bleeding and clotting problems together, that sounds like a consumptive process. We got to think about DIC. A normal PT and PTT, by the way, does not exclude von Willebrand's or a qualitative platelet disorder. You always have to interpret the labs in the clinical context. Did they have recent surgery, antibiotics, renal failure, uremia, alcohol disease, liver disease? You realize that platelets will pump up when I cut you, when I stress you out, because those are inflammatory markers as well. So that could be a compensatory mechanism. In fact, in the setting of acute bleeding, it's not abnormal to see the platelet level go straight up initially. So you want to use this three-step mental flow every time when you're approaching these disorders to decide if your index of suspicion is raised or lowered. Basic labs, they map you to platelet versus factor versus consumption. That's the CBC. The pattern match tests confirm the mechanism, PT, PTT. This keeps your evaluation focused and pathophysiologically driven. So exactly what you need for primary care and follow-up and referral. Okay, so let's talk a bit about hemophilia. The difference between A and B is that A is a factor 8 deficiency, and that's the most common, about 80% of cases. And B is a factor 9 deficiency, and that's about 20% of cases. Both are X-linked recessive, typically affecting males, although females are carriers. So how does hemophilia affect the clotting cascade? Well, it impairs the intrinsic pathway. It leads to inadequate thrombin generation, and they cannot form a good fibrin clot. So how does disease severity correlate with factor activity? Well, less than 1% are considered severe. These are the spontaneous joint and muscle bleeders. They get the hemarthrosis and the deep tissue bleeding. They can even develop a CNS bleed with a good sneeze. The moderate ones, they bleed with minor trauma. That's about 1 to 5%. And the mild ones, these are the ones that bleed, with major surgery, trauma, or contact sports. Hemophilia produces deep joint and bleeding, unlike platelet disorders. The platelet disorders cause mucocutaneous bleeding. Mucocutaneous means nosebleed, mucous membranes. Now, the most horrifying one of all of these, the most red alarm, red flag, oh my God, someone is about to be discharged to the eternal care unit. The big one you need to know about is disseminated intravascular coagulation. Now, this is a secondary consumptive coagulopathy. This is never a primary disorder. Something is always causing this condition. The fact of the matter is we need to figure out what's causing it in order to stop it, and we have to do it in the nick of time because once this horse has left the barn, it's very hard to catch. So what happens in DIC is massive thrombin generation. And what happens as a result of having massive thrombin generation is widespread microvascular blood clots. So platelets and clotting factors are being used up to form all these mini clots. Well, what happens is the body is trying to compensate, and so you get this paradoxical state of clotting followed by bleeding, because the body is trying to put the brakes on the clot formation, so it's pumping it out. And the more it pumps out, the more it forms clots. At some point, what happens is you exhaust your clotting mechanisms. You burn it all up. And so as a result, if you don't have clotting mechanisms, then you can start to bleed. So the common trigger for DIC, just so you know, is things like sepsis, trauma, malignancy, and obstetric complications, usually postpartum after childbirth. And the clinical manifestations, the big tell is when someone starts to ooze from their IV lines, or their incisions start to ooze, or they develop some spontaneous petechiae purpura in the setting of one of these insults. They also may develop, as a result of the clotting, organ ischemia, infarction, mesenteric infarction, microvascular thrombi are forming. So I was just checking the chat. So DIC is always secondary, and the key is to find and treat the underlying cause. Factor deficiencies cause deep bleeding syndromes, as in hemophilia A, while DIC is the most dangerous consumptive process, and it produces both clots and bleeding simultaneously. All right, so hemophilia A is the factor 8 deficiency, and B is factor 9 deficiency. A is more common. The lab pattern that you would notice to make you think of hemophilia is the prolonged PTT and the normal PT. And how do you confirm the diagnosis? With the specific factor assay for factor 8 and factor 9. And the way you distinguish hemophilia from von Willebrand's, because both can cause a factor 8 deficiency, the clinical picture. Hemophilia will cause you the deep cutaneous, the deep tissue and joint bleeding, where von Willebrand is usually localized to mucocutaneous bleeding. The cornerstone of therapy, of course, is these are the people that carry their own clotting factors with them, factor 8 and factor 10. So if they have a trauma or they need prophylaxis, then they would infuse the necessary clotting factor. There's another role here for clotting factors, and that's DDAVP, desmopressin. Desmopressin is sometimes useful in mild hemophilia. It boosts both endogenous factor 8 and von Willebrand's. It's not effective, in fact, in hemophilia B. The way prophylaxis is approached is if they have severe hemophilia, you get regular prophylactic replacement as like a standing medication to prevent joint damage. But if it's mild, then they only get it on demand to replace for bleeding episodes. Okay. Now let me tell you about DIC. This is always a secondary complication of something else. Most often, like I said, sepsis, trauma, malignancy, obstetric catastrophes. And the pathophysiology is the trigger of massive thrombin generation, widespread microvascular clotting. The platelets get consumed and factors, leaving the patient more prone to bleeding. The end result is clotting and bleeding at the same time. And the hallmark trigger for this that you're going to notice is oozing at the sites, at the IV insertion sites. They can then go on to develop mucosal bleeding, petechiae purpura, and then eventually limb ischemia, renal failure, and neurological dysfunction is how this eventually leads to death. And the way this is diagnosed, because there's no single test, but it's pattern recognition. So the pattern you're going to recognize, you'll draw the CBC, then you'll do the PT-PTT and check a fibrinogen. So if the prolonged coagulation, low fibrinogen, elevated D-dimer thrombocytopenia, and if you happen to do a smear, you'll see schistocytes, there's your diagnosis. Most times the diagnosis is done with clinical presentation and those lab factors, prolonged PT-PTT, low fibrinogen, elevated D-dimer, thrombocytopenia. You might see this somewhere. Please know the diagnostic criteria for DIC, prolonged PTT, PT, low fibrinogen, elevated D-dimer, thrombocytopenia. You may see that somewhere. All right, here we go. We have about 40 minutes left. We need to cover who needs a transfusion and white cells. So anemia is this is the most common you will see. So anemia is the simplest definition. Basically, when you say somebody's anemic, this means that they have a reduced hemoglobin and hematocrit, and that we're at risk for impaired oxygen delivery to the tissues. Obviously, if this happens slowly, the body can compensate, and the damage will happen slowly over time. If this is in children, what you can notice this through poor nutritional intake or what they call nutrient crowding. So if you've got like a 2-year-old that's drinking 4 glasses of milk a day and they have no appetite and they're not taking in enough nutrients, this person is now anemic because they're not taking in enough iron. So something is causing them to be iron deficient. Obviously, if you're at a period of high growth and development, this will stunt and impair that growth and development, brain development, etc. So in transfusion medicine, this is normally who gets transfused. But before we get to the transfusion, you want to target all those underlying causes. So I'm going to say a little bit about transfusion because this is the end of the road, and then we'll back our way into the less severe things. So transfusion medicine is all about restoring what's missing, the various blood components, while minimizing risk. So anemia and transfusion decisions span through primary care. And the thing you need to be careful for is we need to be very judicious. And you need to not get overly excited with blood work until you clinically correlate it. So keep in mind, 70 to 80% of most of your medical decisions are going to be based on lab work. So interpreting that CBC with the iron studies and a reticulocyte count is going to be essential to guiding your practice. So we're going to talk about, coming up in this portion of the lecture, anemia types: iron deficiency, B12 and folate, anemia of chronic disease, hemolytic anemias. We'll talk about when to transfuse and what products to give. And of course, we'll have to talk about transfusion complications, TRALI, TACO, hemolytic reactions, etc. So here we go. Does every patient with anemia need a transfusion? Oh, there's my face. No, not every patient with anemia needs a transfusion. Management will depend on not only the number, but the cause. So maybe it might be sufficient to replete the iron. Okay, so let's talk about the most common. Iron deficiency anemia. Because it's required for hemoglobin synthesis, without enough iron, hemoglobin production is going to fall. So microcytic hypochromic anemia. That's what iron deficiency anemia will look like on your CBC, microcytic hypochromic. The main cause of iron deficiency in general is blood loss. And the first place you're going to look for this blood loss will be GI or menstrual. Now, in pregnancy, it's a relative deficiency because there's increased demand. So pregnancy and periods of rapid growth and development might be another indication. The next one, which is less popular in the Western world, but is becoming popular as everyone goes on a fad diet or we have real celiac disease, is malabsorption. So if you truly have celiac disease, you may notice iron deficiency, microcytic hypochromic anemia. Also, if you're on a diet that swears off entire animal products, well, this too may cause you to be iron deficient, especially if you're not supplementing. So poor diet is less common in developed countries, unless, of course, it's a condition of affluence in which you then pick a very specific eating pattern, which does not include all the nutrients. What clinical symptoms do patients with iron deficiency anemia often present with? Think about this. What do you think they would present with? Fatigue, weakness, exertional dyspnea, most common, right? Reduced exercise tolerance. And when you do your physical exam, you may notice that they're pale, their tongue is red, they've got some angular cheilitis, they've got these spoon-shaped nails, they're craving inanimate things. We call that pica, so like ice, clay, starch. That is all strongly linked to iron deficiency anemia. So you may notice children seeking out those non-nutritive food sources. That should raise an index of suspicion for anemia. So what is the diagnosis, Pearl, that you should hang on to iron deficiency anemia? Iron deficiency anemia is a diagnosis, not just a lab value. So you always have to find the cause. So in men and postmenopausal women, that's where you're going to suspect things like GI blood loss and rule out malignancy. In children and reproductive age women, that's where you're going to think diet and menstruation as the most common causes. The initial lab test for iron deficiency anemia is going to be the CBC, but also the ferritin. A low ferritin level confirms the diagnosis of iron deficiency anemia. Now, Why can ferritin be misleading? Because ferritin is actually called an acute phase reactant. Inflammation states can make ferritin look normal or high even when the iron storage is low. So don't just assume because it's normal or high, therefore it's not iron deficiency if they're in a inflamed reactive state. So what are some other labs to look at? Well, that's why we look at other labs. So TIBC stands for total iron binding capacity. So think of that as your iron potential. The more TIBC you have, the higher it is, the more iron binding capacity you have. Well, why would you have high iron binding capacity? Because you don't have enough iron. Another test you can do is a serum iron. That can be low. That's a tell that you don't have enough iron. Another thing from the CBC is if RDW is elevated, that too is a tell of not having enough iron. So you can use the multiple lab indicators to help build and support your index of suspicion to make the diagnosis. But the classic pattern for iron deficiency anemia, which can be microcytic, which is microcytic hypochromic, but other things can also be microcytic hypochromic, but it's most common in iron. The most classic pattern for iron deficiency anemia is low ferritin, low iron, increased TIBC, increased RDW. So if you see that, you can make the diagnosis. So once it's confirmed, what do you think that the first line management would be? Number one, identify the underlying cause. Is it a GI bleed, menorrhagia, malabsorption? If it's malabsorption, then you need to replete it. And you can do ferrous gluconate, ferrous sulfate, venifer, IV, whatever you do. When you give iron by mouth, though, you want to give it with vitamin C. It enhances absorption of iron. So iron with a vitamin C supplement, that can help you boost it up. Now, of course, you have to look for down the stream constipation and if hemorrhoids are a factor. So all of that needs to be addressed more holistically. I'm just focusing on the iron portion for now. When you get to primary care, you can get to the details of how to exactly. So how do we know that iron treatment is working? Well, in about 5 to 7 days, you might notice a bump in the reticulocyte count. Hemoglobin, though, takes about 2 to 4 weeks to improve. So you're not going to see that right away. So if you want a crude measure, come back in a week. The only thing you see is reticulocyte count. But normally you give them iron for a month and bring them back, and then we check. And then you continue iron therapy for about 3 to 6 months after it normalizes, and hopefully we've dealt with the underlying cause. Always replete iron before you go to a transfusion in a stable patient. Transfusion does not fix the deficiency, it just buys you time. In perioperative patients, IV iron can reduce the need for transfusion if surgery is near. And in men and postmenopausal women, iron deficiency equals a GI bleed until proven otherwise. So iron deficiency means whack the stool, send them to GI. They might need a colonoscopy, okay? There are 2 things to keep in mind. Iron deficiency anemia management, you want to replace the iron and find the cause of the loss. So what type of anemia do you get with B12 and folate deficiencies? Well, these are the megaloblastic anemias. These are large, immature red blood cells caused by impaired DNA synthesis. So why does B12 deficiency impair DNA synthesis? Well, B12 is required to convert homocysteine to methionine and methylmalonic acid. So without it, DNA synthesis falters. So hang on to that term, methylmalonic acid, because without enough B12, you're going to develop some neurological dysfunction from methylmalonic acid accumulation. So there's an interesting test to test for this. You can either do folate and B12 on the blood count, on the, to test it in the serum. The problem with just testing folate and B12 is that just tells you that it's in the system. It does not tell you if it's being used. So there's another test called methylmalonic acid, MMA, which is a metabolite of use. You want to think of methylmalonic acid as the TIBC equivalent to B12. If MMA is high, that means you have a lot of B12 potential. And the reason you have a lot of B12 potential is because you don't have enough B12. The other thing is if you oversupplement the folate, you can falsely elevate the B12 on the test, but it doesn't mean you're actually having enough B12. And it's the B12 deficiency that causes the neurological problems. So, yeah, you can do folic acid and B12 level, but most people are doing methylmalonic acid and homocysteine level. The homocysteine level is the tell of sufficient folic acid in the blood. They call this sometimes pernicious anemia. And the reason it's called that is this is an autoimmune destruction of gastric parietal cells. That's the reason you can have a B12 deficiency. So when you eat B12, your duodenum is making intrinsic factor. But if you have something destroying the gastric parietal cell or the intrinsic factor, you can put it down there, but you're not going to absorb it. So that's the problem as to why they inject the B12 rather than take it by mouth, because it bypasses the need to absorb through the parietal cells, and you can just inject it and absorb it through the vascular and intramuscular route. So the way B12 and folic acid is diagnosed is it's a macrocytic anemia. That means high MCV. The peripheral smear may show you hypersegmented neutrophils. You may see a low serum B12 or folate level, and methylmalonic acid will be high for B12 deficiency, and it should be normal in folate deficiency, but high in both. Homocysteine is high in both. And how do you treat them? Well, you replace them for one with B12, IM, high dose B12, or interestingly enough, it turns out if you give high enough oral B12, that can be sufficient rather than inject them, because the injection is labor intensive. But injection brings people into the office, and injection peddles well, and it's red, so people think they're getting something very important and very powerful, and they think they're getting a blood shot. They're not. You can give oral B12, 2 milligrams, fine, and they'll get enough of it if they have intrinsic factor deficiency. You always want to check the B12 before giving folate, because folate repletion can correct the anemia, but leave the neurological deficits because the B12 has never been addressed. So just mark that in your mind, neurological symptoms with B12 deficiency, not folate. And if they're truly pernicious anemia, and the way you can check it, actually, there's a test called an intrinsic factor antibody. If they have that or GI has scoped them, they may need to be on lifelong B12 supplementation. I don't fight a lot of battles on B12. It's a water-soluble vitamin. If someone insists they have to have it because it gives them energy, even though all the tests are normal, fine, let them have it. I don't fight them on that one. That's not a hill and a battle I'm willing to die on. What about this anemia of chronic disease? Now, this is very common. Now, take a look here at these inflammatory markers and cytokines here. Anemia of chronic disease is usually normocytic, normochromic anemia. That means normal MCV, normal MCH, low hemoglobin. And it can sometimes be microcytic. Now, rarely, but sometimes. The key pathophysiologic process here is this is due to chronic inflammation and increased hepcidin, a liver-derived. Hepcidin traps iron. That's how come if the hepcidin is driving it, that's how you'll get a microcytic, if the hepcidin is trapping the iron in the macrophage, which reduces intestinal absorption. That results in the iron-restricted erythropoiesis, and that's how you can sometimes have an anemia of chronic disease that happens to be microcytic. But in general, it's not. It's inflammatory. It's IL-6 mediated. And who would have this? Well, you're looking for someone with a chronic disease state. Like what? Tuberculosis, HIV, chronic kidney disease, autoimmune, lupus, rheumatoid arthritis, inflammatory bowel disease, chronic kidney disease, I said that, and malignancy. Those are chronic disease. Inflammation secondary, like say diabetes, which affects the kidneys eventually, hypertension, which affects the kidneys eventually. So that's who's got anemia of chronic disease. And the characteristic lab finding in this will be low iron, low TIBC, because remember, with iron deficiency anemia, the TIBC should be high, Normal or high ferritin, remember ferritin's a nonspecific inflammatory marker, and usually normocytic. So how do we distinguish anemia of chronic disease from iron deficiency anemia? Anemia of chronic disease, low iron, low TIBC, normal to high ferritin. That's anemia of chronic disease. How do we distinguish iron deficiency anemia? Low iron, high TIBC, low ferritin. So how do you treat it? Well, in general, you can try to obviously go after the underlying cause, treat the infections or the autoimmune, malignancy, et cetera. Depending on how bad it is, you may give this person erythropoietin. Sometimes iron therapy, if combined with erythropoietin. Generally, when you give EPO, you want to give iron supplementation with it. And then transfusion if it's severe and they're symptomatic. Anemia of chronic disease is the body withholding iron during an inflammatory state. It's a protective but maladaptive response. So you always want to rule out a concomitant iron deficiency because the two can coexist. So you want to treat that as well if they do happen to have it. Okay. So let's talk about hemolytic anemia now. Hemolytic anemias means these cells are dying. They're breaking open and leaking out their inside. So anemia is caused by premature destruction of a red blood cell, either intravascularly, that is in the circulation, or extravascularly, that is to say the spleen is in overdrive. So the main mechanism of hemolysis, if it's intrinsic, it's a red blood cell membrane defect. The enzyme or hemoglobin abnormality can be hereditary. Essentially is not of good quality that it's leaking out. Another condition called G6PD deficiency or sickle cell disease or thalassemia, those are all reasons to have a red blood cell defect. Not everybody with thalassemia has it. If they have a pathology like an intrinsic defect, that's when the thalassemia is pathological. The other way, of course, is you can have an extrinsic factor. So extrinsically, that's an immune-mediated response. That is to say, an autoimmune hemolytic anemia. The body is attacking. Mechanical valves can also cause this, as can infections and toxic exposures. So what happens pathophysiologically in hemolysis is that the red blood cell is getting destroyed faster than the bone marrow can pump it out. Hemoglobin gets released. That leads to jaundice, pigmentation, gallstones, and a high LDH. LDH is contained in the cell. In intravascular hemolysis, the hemoglobin binds to the haptoglobin. So remember, when we said in the beginning, you'd have low haptoglobin as one of your tells of a hemolytic anemia. It's low haptoglobin because it's trying to mop up all that hemoglobin. So what lab finding would you see in a hemolytic anemia? We're repeating now from the beginning. Increased reticulocyte count, meaning the bone marrow is trying to respond and pump it out. High LDH, because the cells are lysing and leaking all over the place. High indirect unconjugated bilirubin, that's what leads to your jaundice situation. Low haptoglobin, because haptoglobin's out there trying to bind up all the loose hemoglobin from the cells, leaking it out. And a peripheral blood smear that shows that emergent finding of schistocytes and spherocytes, or maybe some sickle cells, depending on the etiology. There is a test for, there's a test called positive Coombs testing. That's an indication more commonly done in the neonatal population because they can have it early on, especially if they have hyperbilirubinemia in neonates. So if some baby has hyperbilirubinemia, it's not uncommon to do a Coombs test, and that might tell that there's an autoimmune hemolysis process. Usually it's an underdeveloped liver, and eventually that will clear itself. But we can't just assume, we have to look. And the clinical manifestation of any anemia are going to be fatigue and pallor and dyspnea eventually. And in this hemolytic anemia, as we have in babies, jaundice, dark urine, they don't have gallstones, splenomegaly if you're an adult. And so you always want to check what to determine this anemia profile. Always want to know, is it destruction or production? And the way we tell that is we're checking the reticulocyte count. It tells you if the marrow is responding. And if they have a low haptoglobin, high LDH, high indirect bili, That's a strong evidence for a hemolytic state. Remember those TTP, HUS, DIC situation? That's what we're talking about there. Now, no hematology and benign hematology lecture will be complete until we talk about sickle cell disease. So what causes this? This is an adaptive response given certain areas, but this is a point mutation on the beta globulin gene. It's an abnormal hemoglobin S. When deoxygenated hemoglobin S polymerizes, red blood cells get deformed into sickle shapes. They get fragile, sticky, and can potentially become obstructive. Just because you're a carrier does not mean you will manifest this. And so what's the problem here? Well, the problem is the sickled cells are very fragile, causes a chronic state of anemia, and it can lead to jaundice and gallstones. In the emergent state, these sticky, mal-shaped red cells can block small vessels. Well, what do you think happens when you block the blood flow? You get ischemia, which leads to pain crisis, which leads to organ damage, right? It can infarct the spleen and cause repeated vaso-occlusions. So they may develop what's known as a functional asplenia. You can either remove the spleen, that's asplenia, or you can block off all circulation to the spleen, and that's a functional asplenia because it's clotted off. Very high risk for infection. So the hallmark manifestations of sickle cell disease is going to be the same as any other anemia, but the big tell often is this pain crisis, severe bone pain because the bone is not being perfused, chest syndrome, or abdominal pain. So they get referred to hematology given the downstream findings, usually in an emergent setting, and that's how we make this diagnosis. So what triggers it? Well, dehydration, infection, cold exposure, stress, hypoxia, all the activities of daily living in the Northeast. And so the preventative mechanisms are obviously stay well hydrated, prevent infection, keep warm, reduce your stress, acute cases you get oxygen, those sorts of things. And opioid analgesia should not be withheld in this population. So that is sickle cell disease in a nutshell. Now let's talk about these transfusions here. Now, unless you're working in acute care or a transfusion center, which is not uncommon for NPs to be in, or in CRNAs, main blood components can be transfused are red blood cells, platelets, plasma, and cryoprecipitate. So RBCs, that's the first thing we give for symptomatic anemia or acute blood loss. RBCs contain all the clotting factors as well. It's kind of the fastest thing to give. In general, you want to be judicious with this. If someone is reasonably stable, you want to wait till their hemoglobin is less than 7 or less than 8 with cardiac history. That's who you're going to transfuse. Otherwise, you want to go for the other factors that are missing in order to transfuse. So platelets, that's given for thrombocytopenia, platelet dysfunction. Usually, if it's less than 10,000, prophylactically, they'll get it. Less than 10,000, they can get a prophylactic platelet transfusion. Or if it's less than 50,000, but they're having symptoms, like what? Bleeding. Then they can get a platelet transfusion. Fresh frozen plasma, that's for multiple factor deficiencies. That's like, I don't know what you have, or someone put you on warfarin, and I just need to reverse all the clotting factors in you, or you're in DIC, or you have liver disease. Well, then that's the one that's getting fresh frozen plasma. And then finally, cryoprecipitate, that is the one for hypofibrinogenemia. So if your fibrinogen is less than 100, right, which you checked when you were doing your DIC test, right, you checked the fibrinogen level. If it's less than 100, you can give them fibrinogen, which is the von Willebrand factor, factor 8, and factor 8 rather. Now, separate from this, what's gotten very popular in the war zone and trauma, and when I was in Iraq, what was very popular there was factor 8 directly infusing. So in times of trauma, factor 8 can be given. It's expensive, it's easier to give, but something to keep in mind. Now, what about DDAVP? I told you about that for von Willebrand's type 1 in mild cases. Oh, what about calcium? So if you invoke a massive transfusion protocol, a massive transfusion protocol is if you give more than 4 units very quickly. What happens is there's citrate stored in the blood in that bag to keep it from clotting so you can infuse it. Well, the problem with that citrate is it can now trigger hypocalcemia, which can lead to hypotension and arrhythmia. So the problem, of course, is if someone's getting those 4 units of packed cells, you're going to need to give them an AMPA glucose behind every 4 units, essentially, to make sure that we don't mistake the hypotension for bleeding, and really that's a calcium deficiency. And you also don't want to deal with arrhythmias and tetanus and the like. So that is something to keep in mind if you're doing massive transfusions. The best practices for transfusions is to be as restrictive as possible. Don't give 2 units if 1 unit will suffice. Make sure you do a follow-up H&H. And remember, always type in cross-match and warm the blood if possible. Okay. Oh, what can you expect? 1 unit of packed cells should raise the hemoglobin by 1 gram. So something to watch is if you're giving the transfusion and the hemoglobin stays the same, what do you think is still going on? Probably still bleeding. So that's a tell. 1 unit of platelets will raise the platelet count by about 30 to 60. So that's give you some idea how to monitor your transfusion effectiveness. All right, let's talk about transfusion risks and complications. So the most common and most feared complications in transfusions are TRALI and TACO. What in the world is TRALI and TACO? Well, TRALI is a transfusion-related acute lung injury. And the way this presents is it's a donor anti-leukocyte antibody which activates the recipient neutrophils, which leads to inflammation and a capillary leak into the lungs. This typically occurs if it's going to occur within 6 hours of a transfusion. And the tell is you give a transfusion, 6 hours later, your patient is acutely hypoxic with bilateral pulmonary infiltrates and fever and hypotension. They look like they basically got into shock, essentially. It looks a lot like ARDS, but it's non-cardiogenic. So the way you prevent this, ideally, is you want to use plasma from male-only donors or antibody screen donors, because this and you also want to minimize the risk of unnecessary transfusion. So you might be thinking, well, why male-only donors? Well, I'm glad you asked. Male only because they have a much lower risk of HLA and HNA antibodies than females, especially those who have been previously pregnant. Studies have shown that this greatly reduces the incidence by about 2/3. Unfortunately, I don't know of a good way to tell who's prone to having this. And to my knowledge, we don't only use plasma from males. So that might be more academic. Now, what about TACO? Well, TACO is transfusion-associated circulatory overload. It's too much volume too fast. And this presents with dyspnea, hypertension, pulmonary edema, and elevated brain natriuretic peptide, which is a sign of heart failure. This is usually as a result of giving the transfusion too fast in a compromised patient, either an elderly or a CHF patient or someone that was already fluid volume overloaded. This is the person that say, give the blood and chase it with Lasix. Okay, because they want to prevent the circulatory overload that can happen. Now, another complication that can happen in transfusion is this hemolytic transfusion reaction. This is usually due to ABO incompatibility, and you'll know this because you'll give it, and within minutes you'll see fever, flank pain, hypotension, and hemoglobinuria. How do you see hemoglobinuria? You start to see blood in the Foley bag. That's a way to tell, oh, I better stop the transfusion. This is dangerous because this can proceed to DIC and renal failure. Now, that's nice when it's acute because you can see it and intervene. The problem is you can have a delayed version of this called delayed hemolytic reaction. This kicks in days to weeks later. So this can happen from minor antigen mismatches, and they'll present with jaundice and a falling hemoglobin. The prevention mechanism is strict type and cross-match and double check the blood at the bedside. So by the way, when you consent somebody for a blood transfusion, the reason we're consenting them is because there is risk of these complications. And we say things like fluid volume overload, infection, and reaction, right? We say it like that to make it more palatable. But in reality, this is really what we're talking about when we say we need to consent somebody for a blood transfusion, which a lot of NPs are in the role of doing. Now, what are some other common but less severe things that can develop? You can get a febrile non-hemolytic reaction. That's a cytokine release. You get fever and chills most commonly, and a white cell reduction. You can have an outright allergic reaction to a transfusion, hives, itching, usually mild. You treat that with antihistamines. If the ABO compatibility was, and the blood was double checked, it's kind of like, I don't know what's causing it, but there seems to be an allergic reaction, and hopefully the benefit is outweighing the risk. And sometimes, interestingly enough, it's more common with platelets. So you will see that in some places, they will say pre-medicate the patient with Tylenol and Benadryl before transfusion of platelets. Some do it before transfusion of any kind, because they're trying to mitigate that. And then anaphylaxis is rare. That's usually due to IgA deficiency with anti-IgA antibodies, and that requires IgA deficient products. So if your patient is known to have a primary IgA deficiency, like we talked about in week 1, then that's the person that needs, when you order the blood, they need an IgA deficient blood product. Okay. So let's talk about now white blood cell disorders. So there are 2 main categories of white cells, and you'll have noticed that every time we talk about something, we always say there's 2 categories. The 2 categories are always, are you making enough, and is what you're making sufficient, meaning qualitatively sufficient? Well, the same rule applies to white cells. Are you making enough, and are they of good quality? So it's a quantity versus quality. So what does leukocytosis usually mean? Well, cytosis usually means a condition of, means an overproduction. And why you would overproduce white cells, hopefully they're good ones, is often because of infection, inflammation, stress, or steroid use. Now that's important, because if you think about how many times a patient gets admitted and the white count is elevated, or they come out of surgery on day 1 and the CBC in the morning shows a bumped white count, those aren't infections. Those are usually stress-related or inflammatory-related responses. The key is you want to distinguish this white blood cell leukocytosis from leukemia, which we'll talk about blood cancers at another time. But for now, you want to distinguish from leukemia. And the big tell is you want to look for blasts or immature forms and the overall clinical context. So that's how you're going to distinguish it. The other way around the white cells, though, is leukopenia, and that is I don't have enough. So all penias are I don't have enough. Now, why might you not have enough? Well, several reasons. Viral infections can be suppressing your bone marrow from producing. Autoimmune disease, bone marrow suppression, chemotherapy, or if you're on an atypical antipsychotic like, say, clozapine, but it's a class effect. So any of the atypical antipsychotics can suppress your neutrophils. So you always want to correlate the infection history and medication use with the neutropenia. Now, we don't typically get too excited about neutropenia unless it's severe. So severe neutropenia means less than 500. That means they're very high risk for bacterial and fungal infections. And the causes of that can obviously be chemotherapy, radiation, aplastic anemia, meaning bone marrow suppression, autoimmune process neutropenia, or someone that's on clozapine. Clozapine has a neutropenia protocol that they're supposed to follow. So if it drops down, you need to stop it. And then white blood cells can be normal in number, but they can also still be dysfunctional. So that's the quality factor. Things like what? Chronic granulomatous disease, like what? Like tuberculosis, right? So that's why we want to treat the latent TB before it becomes active, because in a chronic granulomatous disease, we may mute our white count and our ability to respond. So leukocyte adhesion deficiency, so that's a failure of neutrophils to migrate to where they need to go. And these are both rare, but they remind you that function matters as much as the blood, as much as the number of cells. So what clinical feature should raise your suspicion for a white cell disorder? Well, if they're leukopenic, neutropenic, you want to think about recurrent infections, oral ulcerations, poor wound healing, and sepsis. That's painting a picture of leukopenia and infection. Now, if they have too much white blood cells, leukocytosis, again, fever, localized or systemic infection, or stressor. The stressor can be, guess what? Your test is going to be today. And then all of your white count just surged and your heart rates all just went up. And that's enough to do that. Eosinophilia, keep that in mind. That is, remember we talked about the eosinophils, wheezes, and strange diseases. So allergy, asthma, parasites, drug reactions. And monocytosis, that's typically associated with chronic infections, inflammatory and recovery. So if someone comes in and says, I was sick and I noticed a monocyte is bumped, usually what that is the monocytes are cleaning up from the last infection they had. Now, I'm not going to hurry have them back, but I will check it again in a few months and see, is this monocyte still elevated? If it is, now we need to worry about autoimmune disease or some sort of chronic infection or something, because these monocytes should have recovered several months after your infection. And if they're still up, then we got to worry about it. So that's why it's really important to always look at labs in terms of a trend. Snapshot labs are useful, but trended labs are much more useful. So always interpret the white blood cell in relation to the clinical context. Not every leukocytosis is leukemia, and not every neutropenia is due to chemo. And the routine CBC abnormalities may be the first sign of drug toxicity or systemic diseases. Okay. So here is a white blood cell chart. What does leukocytosis usually mean? Most often, infection, inflammation, corticosteroids. Distinguish it from leukemia because of the lack of blasts in the white count. The main cause of leukopenia, viral infections. What do we call neutropenia and why does it matter? Agranulocytosis. Less than 1,500, you buy the diagnosis of neutropenia. Less than 500, we call it severe. The classics of eosinophilia: allergies, asthma, parasites, infection, drug reactions, certain malignancies. You can think about the mnemonic NAACP, neoplasms, allergies, and asthma, Addison's disease, collagen, vascular disease, and parasites. Okay. So how do we organize hematology problems systematically? Again, it's who clots, who bleeds, who needs a transfusion, and are there white blood cells protecting them? So who clots? Number one, excessive thrombin generation, factor V Leiden, prothrombin. Also who clots? Loss of natural anticoagulants. That's the proteins C and S and antithrombin deficiencies. Also clotting, acquired triggers like heparin-induced thrombocytopenia, antiphospholipid syndrome, malignancy, immobility, estrogen, pregnancy, right? That's who clots. Who bleeds? Platelet plug problems, ITP, von Willebrand's disease, qualitative platelet disorders, factor deficiencies like A and B hemophilia, and severe von Willebrand's. Also consumptive states. Those are who bleeds. Who needs a transfusion? Anemia, iron deficiency, B12 and folate deficiency, anemia of chronic disease, assuming it is you've dealt with the supplementation and they remain symptomatic. Thrombocytopenia and coagulopathy with active bleeding, they need a transfusion. It's always guided by symptoms and risk, not just the numbers. Except when we're talking about hemoglobin. If it's less than 7, we transfuse them. If it's less than 8 with cardiovascular risk factors, like they've had a heart attack, then we transfuse them. And what about white blood cells? We want to know, is it a quantitative or a qualitative problem? Quantitative means too many or too few, leukocytosis or leukopenia. Qualitative, the white blood cell is present, but it's not working, like in chronic granulomatous disease. Both impact the infection risk. So this hematology, as you see, is a balance of clotting versus bleeding, production versus destruction, immune defense versus vulnerability. Pattern recognition is key. So you want to link the pathophysiology to the presentation. So you always ask yourself, are they clotting? Are they bleeding? Do they need blood? Are their white cells working? So the most common abnormalities are seen in the CBC with fatigue and infection. That's who you're going to work up. Mild iron deficiency anemia, they get an iron supplement, look for the source. New thrombocytopenia plus systemic illness, check HIV, hepatitis, autoimmune disease. Counseling is essential. Remember to reduce the oral contraceptives, smoking, obesity, immobility, and people having clots. Remember that people will often have overlapping risk factors. Take a look at this case here briefly. This is a young woman who develops a deep vein thrombosis while taking oral contraceptives. Oral contraceptives increase clotting risk by raising the procoagulant factors. Inherited thrombophilia like factor V Leiden or prothrombin G2021OA may remain silent until combined with a trigger like the oral contraceptives. So our diagnostic approach is going to be to confirm the clot with an ultrasound, do a CBC and coagulation studies, if it's which will be normal in factor V Leiden. Consider thrombophilia workup if there's a family history. Remember, thrombophilia testing is not always indicated with a first provoked clot, but if she continues to have this, then you need to pursue it. Acute management is you treat the clot and then you reduce the offensive agents, and then you can do the complete workup after treating the clot. Case 2 here, you have a child with recurrent nosebleeds. So the way you're going to distinguish platelet versus factor defect, the child with recurrent nosebleeds and easy bruising, this is mucocutaneous, which strongly suggests a platelet or von Willebrand factor problem, not a coagulation factor problem. If the platelet disorder, is it quantitative or qualitative? Are we looking at primary hemostasis is impaired? That's superficial bleeding, petechiae, purpura, mucosal bleeding. The diagnostic approach here is going to be the CBC with platelet count to distinguish the thrombocytopenia that is low from von Willebrand's, in which the count will be normal. Maybe you'll do coags here, PT-PTT, which will often be normal in a platelet disorder. The APTT may be prolonged in von Willebrand's. And then management, if it's type 1, they can get DDAVP to release stored von Willebrand factor or factor 8. Definitely a hematology consult to distinguish the type. Okay. All right, now we have this elderly patient. Looks like a case of anemia of chronic disease in the context of chronic kidney disease. An elderly patient presents with anemia with a history of CKD. Notice the diagnostic workup. CKD due to decreased erythropoietin production by the kidneys. There's chronic inflammation. There's increased hepcidin, which is blocking the iron release from the macrophage in the gut. There's a functional iron deficiency resulting in inadequate RBC production. So the diagnostic approach here, CBC, usually it's normocytic, normochromic anemia. Iron studies can show a low serum iron. The TIBC will be low to normal, which contrasts this from an iron deficiency anemia. The ferritin, or high or normal, will reflect the iron sequestration. The reticulocyte count will be inappropriately low, which tells you they're not keeping up the production. That's why these people are usually getting EPO to stimulate that production. So you want to correct any reversible causes. Consider supplementation with EPO. You need to have a hemoglobin of less than 10 to qualify for EPO, and you don't want to have a hemoglobin of more than 11 when you're getting it. The risks are high for CVA and blood pressure, hypertension. So you have to be careful with EPO. The benefit really needs to outweigh the risk. Finally, this is case 4, a post-operative patient who develops a drop in platelet count. The differentials are broad and certain life-threatening cases need to be ruled out. The number one thing you need to think about is a heparin-induced thrombocytopenia, which can happen 5 to 10 days after heparin exposure, sooner if they've previously been sensitized, meaning in the last 100 days. Antibodies against heparin PF4 complexes, which inhibit platelet activation and thrombosis risk. The paradox in this is that the platelets are falling, but they're forming clots. You also need to consider sepsis, DIC, which is a consumptive process, because there you'll also see thrombocytopenia, coagulopathy, and bleeding. These are ones oozing at their site. Other things to consider in the post-op setting would be things like a dilutional thrombocytopenia, say after a massive transfusion or fluid resuscitation. A drug-induced thrombocytopenia, say after certain antibiotics like vancomycin or linezolid. Some anticonvulsants can also drive down platelets. So you want to review the timing of the thrombocytopenia in relation to the heparin exposure. Check the CBC, the peripheral smear. You want to rule out clumping. They'll tell you that on a CBC too. They'll say low platelets and they're clumped together. So then you have to manually look. The other thing is if you suspect heparin-induced thrombocytopenia, obviously you want to stop the heparin and then you're going to treat the clot. And you don't want to start the warfarin until the platelets are over 150. That sets the stage for something called skin necrosis. Just something to keep in mind. Okay. So what do I want you to take away from the framework? So this framework, Who Clots? Inherited factor V, prothrombin, protein CNS, antithrombin deficiency, acquired HIT, antiphospholipid syndrome, malignancy, immobility, estrogen pregnancy. Most clots are acquired. Don't jump to genetic testing before checking clinical context. Who bleeds? Platelet disorders, ITP, von Willebrand's, qualitative platelet defects. Factor deficiencies, hemophilia A and B, severe von Willebrand, consumptive states like DIC. Those are the ones that are going to bleed. Remember, the pattern of bleeding is your fastest clue. Mucocutaneous, that means platelet and von Willebrand. Deep tissue and joint, go after the factors. Who needs a transfusion? Anemia deficiencies, hemoglobin less than 7 or less than 8 with cardiac. Platelets less than 10 prophylactically. Platelets less than 50 if they're bleeding. Transfusion's powerful, but let's not forget the risks. White blood cells, look for quantitative versus qualitative. Do they have too many or too few? And always interpret the white blood cell in terms of context, exposure to infection, drugs, marrow suppression, autoimmune disease. So if you remember this, this will at least give you an order of operations as to how to proceed with immune or with hematologic issues. Anyone has any questions, I will take them now.